persistent stigma associated with leprosy. These stigma leads to early diagnostic delay and treatment adherence, which also weakens our effort for elimination or eradication of the disease. Stigma is not a social issue alone. It affects clinical outcomes. What we repeatedly observe in communities where we work: fear of social exclusion, concealment of early symptoms, livelihood insecurity and job loss fears, marital and family rejections because of the stigma, misconceptions about transmission, higher impact on women and marginalized group. These all the factors very much associated with the stigma. Now, GLRA has been working in India since 1966. We are working in 12 states and 98 districts, and we are implementing our initiative through NLEP and our hospital partners. At present, GLRA are supporting 8 tertiary care hospitals for leprosy care. Our focus is community and institutional engagement, and we always develop our programs from our long-term field observation or experiences. Now, I will specifically talk about our flagship program, that is Nirmaya. Since 2018, we are actively implementing this program, where we focus on high endemic and hard to reach areas. We designed this program to integrate stigma reduction into care delivery. We target early detection, disability prevention and inclusion. Now, how we have integrated stigma? Our approach is community engagement and sensitization. We have volunteer-led outreach and mobilization strategies. We do regular skin camps for early detection. We also provide counseling and trust building to the person affected. We also train frontline workers. We build their capacities for the early diagnosis or detection of the disease, and we provide linkage with the tertiary and secondary care hospitals. Now, this is our observed programmatic effects. Through Nirmaya, we have in Nirmaya one program which was from 2018 to 2021, we have identified 1,774 new cases. Through intensive contact screening, we have contacted more than 2,800 family contacts, and more than 192,000 neighborhood contacts were screened. From there, we have identified 185 new cases. Through community skin and disability camp, we have conducted 163 camps so far in Nirmaya, where we have screened more than 11,000 individuals, where we have found 156 new cases. Through our efforts, we have improved community acceptance. More than 76,000 patients, they have received various kind of services. We have improved MDT completion rate by 14%. Earlier it was below 70%, but through our continuous effort, we have been able to achieve more than 85% of the MDT completion rate. Average duration of hospital stay is reduced by 60%. Earlier it was 40 to 45 hospital days, but now it is 18 to 21 days of hospital stay. More than 15,000 Patients affected were provided with self-care kits. More than 500 patients received state-sponsored monthly pension schemes or benefit. More than 200 individuals affected by the disease, they have been provided mobility aids and appliances. Yes, so key lessons for our program. Stigma directly influence case detection dynamics. Early diagnosis requires community trust and acceptance. For that, stigma reduction must be built into routine program activities. Community volunteer and actors, they accelerate detection and adherence. Clinical and social approaches together, they are mutually reinforcing each other. Leprosy eradication requires biomedical as well as social strategies to work together. Thank you, sir.
Good presentation. Thank you.
I would like to call upon our next speaker, Dr. Farid Sarsar. He will be speaking on the peril, limitation and future of AI in leprosy, a retrospective analysis.
Thank you, sir. Respected chairperson, esteemed faculty, and my dear colleagues, I'll be presenting my study on the perils, limitations, and future of AI in leprosy care, our retrospective analysis of leprosy cases using ChatGPT. Early and accurate diagnosis of leprosy remains challenging due to its varied clinical spectrum. Large language models like ChatGPT have shown promising results in varied dermatological diseases. However, their utilization in neglected tropical disease has not been systematically evaluated. This study aims to bridge the gap and evaluate the effectiveness, challenges, and future directions across key areas of leprosy care. Institutional Ethical Committee approval was taken. No patient identifiers were used except for images and morphological details. The AI tool was used only for research purposes, not for patient care and study preparations. The primary objective was to assess the concordance between ChatGPT generated diagnosis and the final diagnosis of leprosy. Secondary objectives include evaluating ChatGPT's ability to classify leprosy on a Ridley-Joplin spectrum, identify reactional states and other variants of leprosy with or without deformity, and provide appropriate differential diagnosis. This was a retrospective observational study conducted in a tertiary care outpatient department. A total of 61 confirmed cases presenting between January to December 2025 were included out of 34,037 patients, accounting for a proportion of 0.18%. Inclusion criteria: patients with clinically confirmed cases, those with available clinical records with high quality images and grade 2 deformity were included, and those with incomplete documentation and uncertain diagnosis were excluded. Clinical data were extracted from the OPD and leprosy registered and verified. Clinical photographs were retrieved from the departmental archives. The patient's identity was anonymized and a standardized proforma was used to collect information based on age, sex, duration of illness, lesion description, any sensory loss, and nerve involvement. A fixed, standardized, non-leading prompt was used for all images to minimize bias and enhance reproducibility. The prompt were: a patient presents with the attached skin lesion, please provide most likely diagnosis, key supporting features, and differential diagnosis ranked in order of likelihood. If Hansen's disease is suspected, please provide spectrum on Ridley-Joplin classification and key features supporting classification. Primary outcome was diagnostic sensitivity of ChatGPT, and secondary outcomes include sensitivity for classification on Ridley-Joplin spectrum, reactional states, other variants of leprosy, and grade 2 deformity. Observations and results. In this case, ChatGPT diagnosis was post-inflammatory pigmented dermatitis on eczema spectrum. The corroborating features include ill-defined skin-colored erythematous patch with mild surface dryness over the retroauricular area. Margins are not sharply raised and there is no nodularity or scaling. The differential diagnosis suggested include indeterminate leprosy, tinea faciae, and seborrheic dermatitis neck variant. The final diagnosis was borderline tuberculoid Hansen's disease. In this case, ChatGPT diagnosis was tinea corporis. The lesion shows multiple annular plaque, raised erythematous scaly, advancing borders with central clearing, and polycyclic and serpiginous margins. The differential diagnosis suggested include plaque psoriasis, granuloma annulare, erythema annular centrifugum. The final diagnosis was borderline tuberculoid Hansen's disease downgrading. In this case, ChatGPT diagnosis was Lepromatous leprosy of advanced nodular infiltrative type, which shows leonine facies. The corroborating features include diffuse infiltration of the face, thickened skin with loss of normal wrinkles, madarosis, and nasal involvement. The final diagnosis was Lepromatous leprosy, which was SSS positive, and the bacteriological index was 5+. In this case, ChatGPT diagnosis was neurofibromatosis, which shows multiple soft, dome-shaped, skin-colored pink papule and nodule of variable size, smooth surface, widely distributed over the trunk. The differential diagnosis suggested was multiple skin tags, molluscum contagiosum, and multiple lipomas. The final diagnosis was histoid leprosy. ChatGPT demonstrated a sensitivity of 37.7%, failing to identify nearly two-thirds of clinically confirmed leprosy cases, reflecting the limited reliability of AI in the real-world leprosy diagnosis. McNemar test showed highly discordance between AI diagnosis and clinician-based diagnosis with a p-value of 0.001. And Cohen-Kappa agreement analysis showed poor agreement beyond chance. In our subgroup sensitivity analysis, AI performance varied markedly across the Ridley-Joplin spectrum. It was 85.7% in the Lepromatous poll, whereas in contrast, it was just 12% in the tuberculite poll. And AI fails to identify mid-borderline, pure neuritic, and histoid cases. The present study evaluated the diagnostic utility of ChatGPT in the retrospective analysis of confirmed cases of leprosy. ChatGPT performs better in advanced and classical forms of leprosy, but has significant limitations in early disease, borderline spectrum, reactional states, and rare variants. This becomes important as early misdiagnosis contributes to ongoing transmission and irreversible nerve damage. Current AI cannot replace clinical expertise, however, they may serve as an adjunctive screening tool in primary care settings to flag suspected cases for early referral. Integration of AI must always follow a human-in-the-loop model. The limitations of the study include retrospective design, single-center data, small sample size, and absence of control group. And the AI model evaluated was not dermatology-specific. However, this study still provides real-world evidence on the current performance of AI tool in leprosy care. Limitations of AI in leprosy. Leprosy is not purely visual, it requires sensory testing and nerve palpation, the component that AI cannot perform. There is a lack of data from the most prevalent countries, and without robust representation, AI model fails to perform. Poor generalization in the endemic region further limits its implementation. Future of AI in leprosy. Leprosy requires multimodal AI integration, and predictive models should be developed which can predict reaction risk, disability risk, and MDT adherence. There can be development of algorithmic tool for detecting cluster trends and hotspots in high endemic areas. Despite growing enthusiasm for AI in dermatology, our study demonstrates that current AI tools show poor sensitivity and agreement in leprosy diagnosis, highlighting that clinical expertise remains indispensable in endemic settings like ours. AI in chronic disease with varied presentation should always be cautiously integrated. And with responsible integration, AI may contribute to achieving the WHO goal of zero leprosy by 2030. These are my references. Thank you.
Fantastic presentation. I think AI is the new thing in our department in dermatology.
Yes,
So I hope it helps us in better analysis.
Yes,
Thank you for your presentation, sir.
Thanks.
I would like to call upon Michael Palapati to present his work, Translating Prevention to Practice, a District Food Health Model for Leprosy and Diabetes.
Good morning, everyone. I'm Michael Palapati from Blue Peter Public Health and Research Center, Hyderabad. At the outset, I thank the organizing committee of Lepcon 2026 to present about my work. This particular project is funded by the ICMR. It's an integrated approach where we are addressing the peripheral neuropathy, both diabetes and leprosy. Since this is the context of leprosy, I would like to concentrate more on leprosy this morning. So the presentation title is Translating Prevention to Practice, a District Food Health Model for Leprosy and Diabetes. As I told you, this is funded by the ICMR. The primary recipient is the Usmania Medical College Hospital, where Dr. Kuduganti Nilaveni is the PI, and I'm one of the PIs. And the peripheral neuropathy, the need for early detection and primary care. It's common but undiagnosed complication of diabetes and leprosy at primary care level. As in leprosy, it is the grade 2 disability is 1.88% presently as per the NLEP 2024 and 2025 report. And in terms of million population, it is 1.31 per million population. Leads to foot ulcers, deformities and amputations if untreated. Early detection can prevent disability and improve quality of life. Coming to the disability burden and clinical impact, 63% of cases are multibacillary, indicating delayed diagnosis as per the data, and peripheral neuropathy leads to foot ulcers and deformities. Foot complications significantly affect quality of life. Screening at primary care level remains limited due to low awareness, lack of simple screening tools, and weak referral and follow-up systems. Strengthening early screening is essential for disability prevention and leprosy elimination. The objective is to design, implement, and assess an integrated district healthcare model that strengthens early identification, referral, and management of peripheral neuropathy in diabetes and leprosy through capacity building and system strengthening. This particular project is implemented in Medchal, Malkajgiri district of Telangana, where we are taking the 12 primary health centers, the 24 urban primary health centers, and the 25 well-to-do or Basti Dawakhanas. The model comprised 3 interlinked components. To start with, situational analysis was done, followed by capacity building, and then next we are going to recruit the study subjects into the project. With regard to situation analysis, a cross-sectional qualitative study involving 236 in-depth interviews with medical officers, paramedical staff, ASHAs and patients assessed gaps in awareness, diagnostic practices, and health-seeking behavior. To share about the qualitative analysis of the in-depth interviews, in regard to the medical officers and staff nurses, under diagnostic practices, knowledge and protocol gaps were identified, and they didn't have particular tools, but the improvised tools that they have is a ball pen that is readily available to check for any nerve function impairment, particularly the sensation. Treatment and medication practices, it's limited to provision of the medication and system-related challenges like stock-out situation and lack of follow-up and monitoring. Patient adherence and barriers, socio and behavioral barriers, particularly substance use. And also, if at all, they visit the health center to collect the medication. Theme 2, the ASHAs and the AIIMS, knowledge and practice. Limited knowledge and no formal training on peripheral neuropathy. Patient adherence and barriers. Patient neglect because they prioritize livelihood practices to health seeking or visiting the health center. And then, if at all, they go to the center to collect their medication. Referral and challenges. Refers only severe case and lack of health education camps. There are no health education camps particularly concentrating on peripheral neuropathy, and follow-up and monitoring they are not able to do because of many concerns. Patient perspective. Awareness and foot care practice. There is no prior knowledge about that, and it is self-initiated. If they have a problem, they only go to the system to tell that they have a problem in the feet. Barriers to practice, work constraints, particularly the work timings of the peripheral health center and their work coincide. So at the end of the day, when the visit center is already closed, and economic constraints, travel costs further, they will lose their daily wages for the day. Health facility use, access difficulty, sometimes, especially the elderly people, they need someone to accompany them to the health center. And then they are happy to just collect the medication and push off to their back to home. This is a picture where capacity building of the medical officers, building of the paramedical staff and ASHAs is done. And with medical officers, especially clinical demonstration is done. And how to assess the nerve function impairment and what action is to be done. And we provided the monofilaments and the 128 Hz tuning fork and the necessary protocols. Training modules are developed for the medical officers and the paramedical staff, and then foot risk stratification tool, and then basic foot care and referral, and implementation reporting. Particular formats are there. As per the ASHAs, the signs and symptoms of peripheral neuropathy and what kind of foot care education they have to impart in the community, and what are the early signs are made aware, and when to refer the to the PSC, that's also provided to them. Intervention and evaluation in this project, we are providing enhanced customization using the portal scan. We train the medical officers, particular staff out there where we're using the portal scan, digital portal scan to take the footprints, and then accordingly do the podiatry to nullify the high pressure areas. And referral pathways are established, and ASHAs are being trained for community-based education. So what's the progress made so far? 20 batches of training for 900 healthcare workers in the 9 primary health centers, 44 urban health centers, and the 25 basti dawakhanas. One training of trainers is done, and then awareness or briefing about the project at the district hospital. 4 FGTs have taken place to assess the progress of trainings. And thank you so much for your time.
I would like to welcome Dr. Anjishnu Prakash sir for chairing this session.
I would like to call upon Mr. Sashi Ranjan Kumar to present his work, Library of Leprosy Literature from Ancient Texts to Modern Journals, a Librarian Perspective. Mr. Sashi Ranjan? I would like to call upon our next speaker, Dr. Divya Priyadarshini. She will present on neuroimaging spectrum of CNS and brachial plexus involvement in Hansen's disease.
Good morning, everyone. Today I'll be presenting a case series on topic neuroimaging spectrum of central nervous system and brachial plexus involvement in Hansen's disease. So Hansen's disease, as we know, besides skin, predominantly affects peripheral nervous system. However, emerging evidence suggests that involvement of central nervous system, dorsal root ganglia and proximal nerve plexuses also exist. Magnetic resonance imaging, that is MRI, has proven useful in detecting such subclinical involvement by enhancing the understanding of disease extent. So this study aims to explore the involvement of atypical sites such as central nervous system, brachial plexus and spinal nerve root ganglion through targeted MRI across diverse spectra of leprosy. So all patients enrolled were MDT naive and without any underlying comorbidities. All the clinical examination, including the bedside test like slit skin smear and specific investigation like nerve conduction study, histopath evaluation and PCR for M-Lepre were done for all the patients. Then after confirmation of leprosy, all underwent MRI and then they were later treated with MBMDT and steroids. So this is a flowchart depicting the same. The MRI we used was 1.5 Tesla and the dedicated imaging of suspected peripheral nerve plus the screening sequence of brachial plexus and spinal cord and brain were there. Now coming to our first case, 64-year-old male presented with chief complaint of left facial palsy associated with lag ophthalmos since 1 month, left hand partial clawing since 3 months and single hypopigmented plaque with decreased sensation since 4 months. So the MRI image as shown here, it depicted the coronal section, marked thickening of trunks of right brachial plexus, and axial image showed hyperintensity in bilateral anterior horn cell, that is in spinal cord. So the SSS was negative, NCS was suggestive of sensory motor neuropathy in all 4 limbs, eye, hand, foot score, EHF score was 7, and final diagnosis of borderline tuberculoid Hansen's disease with left facial palsy, grade 2 deformity with brachial plexus and cord involvement was made. Patient was treated and then there was resolution, although we don't have our follow-up pics for all the patient. Now, case 2, 40-year-old male presented with infiltrated plaque. His MRI section, axial section of brain showed hyperintensity in right ventral pons and again hyperintensity in left middle cerebellar peduncle. SSS was 3+, NCS was suggestive of polyaxonal neuropathy in all 4 limbs, EHF was 6 and final diagnosis of BTHD downgrading to BLHD with left facial palsy and with brain involvement was made. Case 3 was 16-year-old male who presented with left facial palsy, which is depicted here by clenching of teeth. There was deviation of the face towards one side, left hand clawing since 4 months, and there was well-defined edematous plaque, single plaque on hand depicting T1R. SSS was negative, NCS was again suggestive of left ulnar sensory motor neuropathy, EHF was 3 and final diagnosis of BTHD with T1R with grade 2 deformity and left facial palsy was made. His axial image of spinal cord showed hyperintensity in left anterior horn cell and then again in the cervical cord in the sagittal section extending from C4 to C7 level. This is the follow-up image after 1 year of MBMDT with oral steroid. There is only residual hyperintensity in left anterior horn cell and the cord involvement also, the residual hyperintensity is left. In case 4 was 19-year-old male who had right-sided facial palsy with Bell's phenomenon 6 months. His axial image showed again hyperintensity in right anterior horn cell and sagittal image showed patchy hyperintensity in cervical cord at C3, C5 level. SSS was 4+, NCS had bilateral ulnar and sural sensory neuropathy, left median and right CPN motor neuropathy, EHF was 4, final diagnosis of BLHD with grade 2 deformity and right facial palsy with cord involvement was made. Case 5, he presented with multiple infiltrated papillonodular lesion all over the body associated with right-sided facial palsy since 3 months and there was left greater auricular nerve thickening associated with some prominence also. So in axial image, we show there was a depiction of hyperintensity in cervical cord and then again sagittal section we saw that there is hyperintensity in cervical cord at C3 and C6 level. SSS was 6+, NCS was right ulnar sensory motor neuropathy, EHF score was 5 and final diagnosis of LLHD with right-sided facial palsy with cord involvement was made. Now case 6, this is a very interesting case because here we got some exclusive findings. 51-year-old male came with well-defined erythematous plaque associated with decreased sensation and left greater auricular nerve thickness and prominence associated with tongue and uvula deviation. Now in the axial image we saw hyperintensity in cervical cord, sagittal section showed patchy hyperintensity in cervical cord at C2 level. And axial image again showed hyperintensity in medulla involving left olivary nucleus and pyramid. SSS was negative, NCS was suggestive of right CPN motor neuropathy, EHF score was 2, final diagnosis of BTHD with T1R with right-sided facial palsy with brain and cord involvement was made. So this is post-treatment follow-up. Here as we see in the left side there is a complete resolution of the plaque with some atrophy and in the second image there is axial T2 image showing resolution of hyperintensity in medulla and also the cord involvement that has resolved. Now case 7 presented with progressive left facial palsy since 3 months and right hand partial clawing since 4 months. Axial image again showed hyperintensity in medulla involving left olivary nucleus and pyramid. Also after follow-up there was residual hyperintensity left. SSS was 4+, NCS was suggestive of sensory motor polyneuropathy in all 4 limbs, EHF score was 5 and final diagnosis of BLHD with grade 2 deformity associated with left-sided facial palsy with brain involvement was made. Now this is a table with all the clinical features and MRI findings. Here we see that cranial nerve involved was 7th facial nerve in all 7 cases, on 6 cases except for 1 case which had brain involvement. Here 10th and 12th nerve was involved. Now, according to the some references which I took, Phulwarisharif, he presented with, he had brain findings similar to our study and also with the cord involvement study. But Jabin et al., he had facial nerve nuclei and nucleus ambiguous involvement in brain and also with cord level at C566 level and conus medullaris. In our present study, we found hyperintensity in pyramidal tract, which is exclusive, and also in the cord involvement, C2 level was found, which is exclusive from our study, and brachial plexitis was the common finding. So what could have actually caused to affect CNS according to Phulwarisharif? Retrograde spread of M. leprae, immunological reaction and transection of axons could be the hypothetical explanation for this. Hansen's disease, they may involve the CNS and proximal nerve plexuses beyond distal peripheral nerves. MRI reveals possibly inflammatory changes that are potentially reversible with early treatment, as we saw. A meticulous neurological examination is essential in all cases of leprosy, and craniospinal MRI should be pursued whenever clinical features raise suspicion of central or proximal involvement. So these are my references. Thank you.
So we have come to the end of the session. Mr. Sasi Ranjan Kumar, is he here? That is left. So if he is not there, we will conclude the session. We will go on with the quiz session. Thank you, everyone. Thank you.
Thank you to all the presenters for their concise and well articulated contributions. We now move to the exciting segment, the national quiz, final round. May I invite our quiz masters, Dr. Anupam Das sir, Dr. Shruti ma'am, Dr. Gaurav Das sir, Dr. Vibhu sir on the dais.
Good morning, everyone. We are about to start the quiz now. And our team, that is our quiz masters, Dr. Anupam Das, Dr. Shruti Kondaviti, Dr. Manvi, Dr. Vibhu, and Dr. Gaurav. So today the quiz will be conducted by Dr. Anupam Das and Dr. Shruti. The scoring will be done by Dr. Manvi, Dr. Gaurav, and Dr. Vibhu. Now I would like Dr. Shwetilana. I would like to call upon Dr. Shwetilana Pradhan so that we will take the chits now because we want to allot the teams to all of you.
कराना बोलिए. आइए इधर आइए.
तौलिया पे चेयर लगा के कहाँ रख दिया? किधर भेज दिया?
Scoring my proper paper Shruti దగ్గర ఉంది madam. So team A, please come and occupy your chairs. Team B, Team C and Team D. We'll start the quiz in few minutes. All the participants, don't be tensed. All the best. All of you will do well. You have come to this level, that means you are all are intelligent, all are good. So I will ask Dr. Anupam Das and Dr. Shruti to take over.
Very good morning, everyone. Welcoming you all to the most exciting part of Lepcon 2026. This is the second national quiz on leprosy conducted on behalf of Indian Association of Leprologists. Thank you, organizing and scientific team, for having us here and do the quiz. Yesterday we had the preliminary round, and let me tell you, all the teams were excellent, and the top 4 teams who have qualified to the finals, they have performed exceedingly well, and the scores were almost very, very good. We are not supposed to disclose the scores, but yes, just for your information, all of them performed equally well, and there was a difference of hardly 0.5 or 1 between the teams. So myself, Dr. Anupam Das and Dr. Shruti will be doing the quiz today. Before I hand over to Dr. Shruti, I would request all the 4 teams to introduce themselves. We start with Team A. Please mention your name and affiliation. We start with Team A.
Dr. Abhijit Brijwasi from AIIMS Nagpur.
I'm Dr. Chetan from AIIMS Nagpur.
I'm
Team
Dr. Garima from MGM Indore.
I am Dr. Akash from MGM Indore.
Team C.
Dr. Suryakant from AIIMS Bhubaneswar.
Dr. Preetham from AIIMS Bhubaneswar.
Dr. Ayushi from AIIMS Jodhpur.
Dr. Tushar Pawar from AIIMS Jodhpur.
Thank you, teams. We would request you to please be clear and loud on mic when you are answering the questions, otherwise it can lead to a bit of controversy. And most importantly, whenever you are answering any question, we request you to please discuss amongst yourselves and give us one answer. Please don't give multiple answers, all right? Your first response will be regarded as the last response. Now I invite Dr. Shruti to take you through the rules and regulations of the quiz, followed by the first round. Over to you, Dr. Shruti.
A very good morning, everybody. I'll just take you quickly through the rules. This is understood, so obviously no cheating. So I request all the audience to maintain silence and not to give any clues. Okay? And then, so from the round 1 to round 8, each question carries 10 marks. Each direct question, you are given 10 seconds to answer. And for each past question, it carries 5 marks. And you are given 5 seconds to answer. And there are no negative markings from round 1 to round 8. So after this, we have rapid fire round, and each question carries 3 marks. Then 10 questions will be asked in 1 minute, and 1 chance to answer each question. And the questions won't be repeated once they are passed. And even here, you don't have any negative marks. So sequence of questioning will be A to B to C to D from round 1 to round 4. And from round 5, it will be from D to C to B to A. So scores will be announced after every 2 rounds. And in case of any questions or any controversies, the quiz master's decision will remain final. So these are the rounds. The first one will be from history, then basic sciences, clinical, dermatopathology, therapy, surgery, social aspects, and recent advances. And the last one, rapid fire. So all the best to all the teams. Do you have any questions, or you understood everything? Are you ready? Can we have a little smile on your faces? Yeah. So we'll just proceed with the first round. Round 1 is on history. So direct question to team A. Identify this person. Time up.
Jacob Shekskine.
Wrong answer.
Ernst Mayr.
Can you be a little louder, please?
Ernst Mayr.
Wrong answer. So, nobody could answer this. The answer is Wilhelm Moller Christensen. He was a Danish medical historian and a paleopathologist. So he was the one who described the facies leprosa. He studied on the changes of the skull. So next question to team B. Pass to team C. Pass to team D. Pass to team A. So nobody could answer this as well. He's the founder of the Leprosy Mission Trust India. He's Wellesley Bailey. So he was a teacher and a missionary. He almost took care of 14,000 lepers for life in his lifetime. So we'll go to the next question. Direct question to team C. Identify this person.
Wahi Sasakawa.
Wrong answer. Team D. Pass to team A. Can you be a little louder?
Paul Brand.
Well done. This is the right answer. We need a little round of applause for at least for the right answer. Yeah. So he's Paul Wilson Brand. So he was the first orthopedic surgeon in the world to use reconstructive surgery on the hands, and he almost changed the perspective of people about how they looked, the leprosy patients, how they looked them. So next question to Team D. Pass to Team A. Pass to Team B.
Antia.
Louder.
Antia.
Wrong answer. Team C. So she is Professor Indira Nath. So she's known for, she's credited for sequencing the LSR2 gene in leprosy-causing bacteria. She's the recipient of Padma Shri, Shanti Swarup Bhatnagar Award and L'Oreal UNESCO Award for Women in Science. So with this, we come to the end of the first round. Over to you, sir.
Thank you, Dr. Shruti. We go to the second round now. Please smile, everyone. It's all right. We start with Team B. Ready? Acanthamoeba, amblyoma, and Rodnius. How do you connect them with leprosy? Team B.
Are they connected with Strongyloides stercoralis?
Team C.
All of them affect the transmission is through the nerve, peripheral nerve.
What do you call it? Those who transmit, what do you call them?
Vectors.
Vectors, yes, vectors. Good answer by Team C. Team C gets +5. Can we have a big round of applause for Team C, please? So Team C gets +5. They are considered to be potential vectors of Mycobacterium leprae. Now we have direct question for Team C. Simple one. Expand NRAMP1. Team C. I want a complete answer. Time's up. Team D. Team A.
Natural resistance associated macrophage protein 1.
Natural resistance associated macrophage protein 1. Very good answer by Team A. Team A gets +5. Okay. So now we have the direct question for Team D. Team D ready? The lipid antigen of Mycobacterium leprae that is presented by CD1b molecules to T cells is. I want to know the name of the lipid antigen. Team D.
PGL1.
Team A.
Lipoarabinomannan.
Very good answering by Team A. Again, Team A gets +5. Big claps for Team A again. All right. So as you can see, all the difficult questions in the quiz have been put by Dr. Shruti, and the simple ones have been put by myself.
Sir's just lying.
Okay. So Team A, very good answering by Team A. Team A gets +5. Now direct question for Team A again. Ready? Simple one coming up. What is the sensitivity of auromin rhodomin stain in detecting M. leprae in indeterminate and borderline tuberculoid cases? Just use your common sense.
%90.
Team B?
0.
Team C?
100%.
Team C gets +5 points again. So this is 100%. The sensitivity is almost 99 to 100%. Excellent answering by Team C. Team C gets +5. So I think all the questions were answered in this particular round. So we move on to Dr. Manvi for the scores, and then I request Dr. Shruti to move on to round 3.
So till now, Team A is at 15, Team B is yet to open, Team C 10, and Team D yet to open.
A round of applause, please. Have you all had your breakfast? Right. So now we'll move on to the round 3, which is the clinical round. The direct question starts from Team C. Okay? So the question is this is the test which is performed by applying light pressure with a blunt instrument along the plantar surface of the foot with a positive result indicated by the patient wincing in pain in ENL.
Ryer's test.
Very good. So the answer is the Ryer's test, or sometimes it is also referred to as part of the Ellis test. So plus 10 marks to Team C. Team D. The characteristic profound anesthesia found in the extremities of patients with untreated advanced leprosy. This sign often appears in the fingers and toes, indicating severe peripheral nerve damage caused by the disease. Can you identify this sign?
Danielson sign.
Right answer. Plus 10 to Team D. Easy, right? So it is named after the Norwegian physician Daniel Cornelius Danielson. Team A. Which dermoscopic feature is specifically associated with hystoid leprosy, resulting from the upward pressure of the dense, well-defined dermal granuloma on the blood vessels? I need the appropriate word that is used here.
Fishtail sign.
Wrong.
Arborizing vessels.
Wrong.
Crowning vessels.
Very good. Right answer is the crown vessels, which is the term that is used here in the dermoscopy, as you see. So plus 5 to Team C. Team B. What is the complication presented here? Identify the nerve branch that is affected.
Zygomatic branch of facial nerve.
What is the complication presented here?
Corneal ulcer. Leg of thalamus and corneal ulcer.
What do you call that? Corneal ulcer?
Anesthesia.
Proper term. We'll definitely give you the mark, but can you just try? What happens prior to the corneal ulcer?
Corneal anesthesia, lag of thalamus. Exposure keratitis.
Exactly. So what we see here is the exposure keratitis, and it is due to the lag of thalamus, and the zygomatic branch is the right answer. So plus 10 to Team B. So here we come to the end of the third round. Over to sir.
Well played, teams. Now we come to the dump path round. We start with Team D. Team D. What are epithelioid contaminants in relation to hystoid leprosy? I want a complete answer.
Well-defined granulomas which are seen in hystoid leprosy. Well-defined epithelioid cells which are seen in hystoid leprosy.
I'll come to Team A. I'll see if I get a better answer. Right? Team A.
The hystoid epitus is interrupted by epithelioid cell containing part where the macrophages are where the macrophages are epithelioid type of macrophage in between, and bacilli will be less in the epithelioid contaminants.
Yes, I'll give it to them. I was waiting for this entire thing, lesions of hystoid leprosy showing epithelioid cells or granulomas without the organisms, right? You don't get organisms here. So I'll give plus 5 to Team A. All right, Team A gets plus 5. Now direct question for Team A. In type 1 lepra reactions, there is a higher expression of FOXP3 positive regulatory T cells. I want you to expand FOXP3. Team A. No? Team B. C? D? Okay, the quiz masters are happy now. Okay. Anyone in the audience? All right. FOXP3 stands for forehead box P3 gene. Yeah. No problem. All right. So, in quiz, some questions will be there which have to make the quiz masters happy. All right. So, no problem. We go to team B now. Ready? Simple one. What is the characteristic histopathological finding here? Just go for it. It's a very simple one. Team B.
Granulomas are present, epithelioid cells are present, granulomas, lymphocytes.
Where is it found? Yeah, we'll give it to you. This is a well-formed tuberculoid granuloma of tuberculoid leprosy. Please be louder on mic, all right? So team B gets plus 10. A big round of applause for team B, please. Team B gets plus 10. Now, direct question for team C. Take your time. Middle-aged man presented with necrotic plaques on the buttocks. Look at both the images, connect them and give me the complete diagnosis. Team C. The clue is there on the right image.
En necroticans.
Okay. We'll see if we get a better answer. Team D?
The Lucio phenomena.
Yes, we will give it to team D. We'll give it to team D. Lucio phenomenon in a patient of lepromatous leprosy. We were specifically looking for the word Lucio phenomenon. Team D gets plus 5. Team D gets plus 5. Of course, you get a perivascular, periappendigeal infiltrator foamy histiocytes and thrombosed and congested capillaries. We took up this question from IGDVL. Can we have the scores now? Over to Dr. Vibhu and Dr. Manvi. Mike.
Yes, okay. Team A is with 20 points. Team B is also with 20 points. Team C has 25 points. And Team D has 15 points.
Okay. Big round of applause for all the 4 teams. Now I invite Dr. Shruti again to take us through round 5. And now just to remind you, we will go in reverse order now. We start with D, C, B, A. Over to you, Dr. Shruti.
So almost all of you are about the equal scores. So please relax and answer. Then you can answer better. So going to the round 5, which is on therapeutics. Direct question starts with team D. So the question is, the drug which could allow for shorter and more effective treatment regimens in treating leprosy, which is baraquilin. What is the most concerning side effect which has black box warning?
The cardiotoxicity, QTC prolongation and arrhythmias.
Right answer. Right answer. Team D. Well done. So the answer is QT prolongation. It can block the HERG channel, causing the dangerous changes in the heart's electrical activity. So the next question to Team C. An oral experimental PGE4 inhibitor being developed to treat severe inflammatory complications of leprosy, specifically type 2 reactions, and has received FDA orphan drug designation. Identify the drug.
Roflumilast.
Can you be a little clearer?
Roflumilast.
You mentioned roflumilast? Roflumilast?
Are you saying roflumilast or what are you saying?
Apremilast.
Wrong answer. Team B.
Roflumilast.
Team A. Team D.
Tenidap.
No. The answer is dovremilast. It works by inhibiting TNF alpha production to reduce inflammation. So, next team B, dose and name of the injectable dipodapsone preparation. It has to be accurate. Passed to team A.
Acid Epson 225 mg 11th weekly, every 11th week.
Oh, dosage also and regime also. Right answer. So team A gets +5 for acetapsone 225 mg. It is diacetyl diamino diphenyl sulfone. Right answer. So now the direct question to team A. In context of drug repurposing, which antiviral drug is being investigated for its potential to block enzymes in M. leprae?
Amantadine.
Wrong answer. Team D?
Lemudine.
Wrong answer. Team C?
Cyclovir.
Wrong answer.
Abacavir.
All virs they have tried, but the right vir they have not said. So the right answer is tenofovir, which is being studied due to its ability to bind to M. leprae proteins. Well tried. So here we finish the round 5. Over to sir.
We go to round 6, which is about surgery. We start with team C. Name the muscle used in Fowler's operation with respect to reconstruction of claw hand deformity. Team C.
Extensor digiti minimi.
Very good answering by team C. Team C gets +10. Big round of applause for team C. They get +10. This is extensor digiti minimi. Direct question for team B. Posterior tibial nerve neurolysis has been used for treating which specific consequence of plantar nerve involvement in leprosy? What specific consequence I am talking of? Team B.
Inversion.
Team A.
Drop foot.
Team D.
Clotose.
Clotose. Team C. So nobody else. We go to the audience. Anyone? Okay, we were looking for this answer. Due to loss of plantar sensation, we were looking for this chronic trophic plantar ulcers. All right, we thought it was a simple one. Yeah. Okay, we now come to team A. Name the muscle used in Antier's operation with respect to reconstruction of claw hand deformity. Team A.
Palmaris longus.
Very good answering. Team A gets +10 again. Team A gets +10, and last question of this round goes to team D. In irreversible ulnar nerve paralysis secondary to leprosy, name this surgical reconstruction technique which gives functional outcome.
The Zancoli lasso reconstruction.
We'll give it to you. This is Zancoli's lasso's procedure. Very good answering. Here what is done is shortening of the finger flexor tendon. So team D gets +10. Big round of applause for all the 4 teams, please. Can we have the scores now? Over to you, Dr. Manvi, Dr. Gaurav and Dr. Vibhu. I think it's going neck to neck. Yeah.
Perfect. Team A is with 35 points. Team B is with 20 points. Team C is with 35 points. Team D is with 35 points.
Oh my God, 35, 20, 35, 35. Big round of applause for all the 4 teams. Thank you, scorers, for keeping a track of whatever is going on. Now we go to round 7 and I invite Dr. Shruti.
मजा आ रहा है ना neck to neck? Huh? So I'm just kidding. मजा नहीं आ रहा है. I know. So now we go to the social aspect, round 7. Direct question to team B. What does this rising sun in this emblem indicate?
Hope and optimism.
Rising sun in this emblem.
Ma'am, hope and optimism.
Yeah, open optimism. So, okay. Right answer. plus 10 to team B. Team A, which WHO region contributes the highest proportion of global new leprosy cases?
Southeast Asian region.
Very good, right answer. It is the Southeast Asia region, SEAR, accounting for roughly 67 to 73% of the total global cases. Next question to Team D. Stigma experienced by family members of patients due to leprosy patients due to the fear of contamination. What is this called? What is this stigma called? There are a few types of stigma, so what is this called?
The untouchability, the discrimination due to untouchability.
Not clear.
The discrimination due to touchability.
Wrong answer. Team C.
Social stigma.
Wrong answer. Team B. Team A.
Perceived stigma.
A little closer, but wrong answer. It is associative stigma or stigma by association, which is also called courtesy stigma. Right? Now the team C, a little maza here. A Bollywood actress who revealed she was diagnosed with leprosy at age 12, just months before being cast for her blockbuster film in 1973, and she successfully got treated for the condition, which appeared on her elbow, and overcame the stigma to become the leading actress. And she often highlights this experience. Please identify the actress. This is Anupam sir's question.
Rekha.
Next team. Team B. Team A. कोई पिक्चर्स नहीं देखते. Team D.
Shaban Azmi.
Oh no. I thought they would have answered this. Audience.
Yes.
The right answer. It was Dimple Kapadia. So we were thinking this would have been easy, but yeah. So end of round 7. Now we go to the round 8.
We come to the last regular round. We start with Team A. Team A ready? What is the mechanism or system used here to assess palmar pressures in leprosy affected individuals? You have to name the system. Team A.
Laser Doppler fluxometer, laser system.
Team D. C. B. On mic.
Action potential.
No, we cannot give it to you. This is the biofeedback system. We were looking for this answer. Nobody gets this? All right. We now go to Team D. What is the ANSYS simulator assessing here? Team D.
The deformity, the contracture of the joint.
We cannot hear you.
So the contractures or the deformities at the...
No. Team C.
The bone involvement.
Team B.
The nerve involvement. The nerve involvement.
Team A.
Pressure.
What do you call it? Yeah. We want the complete. What pressure? What pressure?
What pressure
Yeah.
do we have? What?
Vertical pressure.
Huh?
Vertical pressure, they are telling.
We will give you the mark, but can you try? Can somebody try? This is related to AI.
I think we'll give it to them. Yeah, it is pressure only. The complete answer was peak plantar pressure, okay? Yeah, peaking of the pressure. This is useful to design those customized splints and footwear, and also for correction of foot impairments for leprosy patients, especially who are living in remote places. That is where AI comes into role, right? So Team A gets +5. Now the direct question for Team C. Which next generation sequencing tool is specifically tailored for rapid routine molecular surveillance of drug resistance in case of Lepri? It's something very, very recent. So team C.
RLEP.
Team B.
TAC.
A. D.
Dplex make lepre.
Excellent answering by team D. This is excellent answer. This was one of the most difficult questions of the set. This is Dplex make lep assay. Big round of applause for team D, please. Team D gets +5. We come to team B. Team B ready? Which image processing tool is frequently used before feeding leprosy lesion images to AI models? Team B. You have to name the image processing tool.
EpiInfo.
Team A.
Very simple.
This is very easy actually. Team E. D.
The Learns app. Learns.
No. Team C. Okay, the question goes to the audience. Camera, okay. This is the process of dividing an image into multiple parts or regions that belong to the same class. It is a segmentation process, we call it. Nobody gets this. Now, can we have the scores now before we go to the rapid fire? The quiz masters are tensed now. We have our tiebreakers ready though, but still, yeah.
Yes. Team A is with 50 points.
Team A is 50. Big round of applause for Team A.
Yes, they are in the lead. Team B is 30 points.
Team B 30 points. Big round.
Team C 35 points.
Team C 35.
And Team D is with 40 points.
40 points. Okay. So 50, 30, 35, 40. Right?
Correct.
We go to the rapid fire. Let me explain the rules again. You will be given 1 minute, +3 for correct answer. There is no negative marking. Please discuss, and no pass. Please discuss among yourselves and give us one answer, right? Within 1 minute. And unless you say pass, we won't go to the next question. We will keep on waiting. So if you don't know the answer, please pass. And for past question, there is no negative marks. Yes, and we don't come back to the questions also. Someone please look into the timer also. Yeah. 1 minute.
1 minute time.
Yeah, Gaurav is doing. Team A. Your time starts now. Brodimoprim acts by.
Pass.
Rose rash in leprosy seen in.
ENL, erythema leprosy.
Igawa test is used to evaluate which muscle?
Dorsal interossei.
Instrument used for sensory testing in field?
Ballpoint pen.
Which molecular technique helps detect drug resistance mutations in lepri?
Pass.
In which year did the WHO declare leprosy eliminated as the public health problem globally?
2005.
Which enzyme is most responsible for oxidative stress mediated nerve damage in leprosy?
Nitrous oxide synthase.
Expand SDR PEP.
Single dose rifampicin post exposure prophylaxis.
Correct. Who is the editor of Indian Journal of Leprosy?
Dr. Vishwamohan Katoch.
Correct. What does 2+ stand for in bacteriological index?
1 to 10 bacilli, 100.
1 to 10 bacilli?
10.
Okay, we'll give it to them. We'll give it to them. So you answered ENL correct. You answered dorsal interossei muscle correct. You answered inducible nitric oxide synthase correct. Single dose rifampicin PEP correct. Vishwamohan Katoch doctor correct. 1 to 10 bacilli and 10 oil immersion fields correct. You got 6 correct. So 6, 3, 18 points. Big round of applause for team A. They get 18 points in rapid fire. Yeah. We go to team B now. Team B, your time starts now. Which transcription factor is upregulated in tuberculoid leprosy promoting Th1 differentiation?
Pass.
Which gene mutation causes dapsone resistance?
FOLP1.
The first effective treatment for leprosy was?
Chalmogra.
Which specific glycolipid of M. lepri is responsible for Schwann cell binding?
PGL1.
Which component of host immunity determines the spectrum of leprosy?
CMI.
The full form of ILEP is?
International Leprosy Administration Program.
Which complement component is heavily deposited in ENL lesions?
TH17. Complement.
Mechanism of
C3,
action
C3.
of fampicin?
DNA dependent RNA polymerase.
British Empire Leprosy Relief Association was renamed in 1950 as? Lepra. Central piece of the nerve biopsy sample should be fixed in? Time is up. I think you answered FOLP1 correct, PGL1 correct, cell-mediated immunity correct. I think that's it. DNA-dependent RNA polymerase.
Did you say
Okay. I think 4 correct, 4 correct. So they get 4, 3, 12 points. Big round of applause for team B. Over to Dr. Shruti for team C and team D.
So team C, are you ready? Which specific domain of laminin does PGL1 bind to in Schwann
Alpha 2.
cells?
Alpha 2.
What is the immunological basis of type 1 reversal reaction?
T helper 1 and T helper 17.
What is the ultimate diagnostic tool in pure neuritic Hansen's?
NAR biopsy.
What is the molecular target of clofazimine in leprobacilli?
Pass.
Which surgical procedure is done in leg of thalamus in leprosy?
Frontalis sling.
What molecular technique is used for early detection in M-lepre DNA?
Pass.
How many months before clinical onset can risk for predict leprosy?
3 months.
Clofazimine belongs to which group of antibiotic?
Pass.
So time up, but still we'll just go with the 2 questions. These are the 2 questions. So the answers are, I think they got nerve biopsy right. That's it, right? Nothing else. So 1 right, so 3 marks to team C. So these are the answers. Moving on to team D. Ready?
Yes, ma'am.
The first question, which macrophage polarization predominates in lepromatous leprosy?
The epithelioid cell.
What is the immunoprophylactic vaccine, MIP?
The Mycobacterium indicus prani or
What is the maximum score of leprosy neuropathy scale?
pass.
Who classified leprosy into elephantiasis graecorum tuberosa and elephantiasis anesthetic?
The Danielson and Broek.
Expand N-list of the N-list severity scale.
Erythema nodosum leprosum severity scale.
The generation time of M-lepre during its logarithmic multiplication phase is?
11 to 13 days.
NLEP is implemented under
Pass.
which antileprotic drug is being explored in the treatment of triple negative breast
Pass.
cancer? World Leprosy Day is observed on?
30th Jan.
The nerve biopsy samples distal 1.5 to 2 centimeter piece should be fixed in. Time's up, but still, we'll just know if they know the answer. Right. So these are the answers. I think they got MIP, Danielson, Boyk, 12 to 15, 11 to 13 they've mentioned, and 30th of January. 3 right? 3 answers. 4? 4 answers. So 4 into 3 is 12 marks. 12 marks to Team D. A big round of applause. They were doing extremely well, so we had to raise the bar, to make this tough for them. It was even tougher for us. So I know the stress level is peaking. So if the scorers are ready, we'll go with the final scores. Do we have a tie?
Yeah.
We do? No tie? Can you announce the scores in ascending order?
First, Team C.
Mike.
Team C is with 38 points. A big round of applause. Team B gets 42 points. Team D gets 52 points. And the winners, Team A, 68 points.
Congratulations
to
Team
everyone.
A, AIIMS Nagpur. Congratulations. So we are grateful, me and Dr. Anupam Das sir and the whole quiz team is grateful for giving us this opportunity. We thank all the IAL. एक बार फिर वो slide रखना please. Presentation. So we are grateful to the IAL for giving us this opportunity. And yesterday we had prelims. And this was the attendance in the prelims. And you can guess how tensed we were looking at the crowd. So we would like to congratulate each and every PG who has attended the quiz and made it this success. And this is our quiz team. I would like Dr. Rajalakshmi Madam to give a few words.
Yeah, excellent work done by Dr. Anupam and Dr. Shruti as quiz masters. Really, they deserve a big round of applause. And next, my team who are scoring neck to neck, and they were so tensed up because I was there with them. Dr. Manvi, Dr. Vibhu and Dr. Gaurav keeping up the time. So it was really very difficult for them too. So a big round of applause for those three of them. And very big round of applause for all the participants who have made it very difficult for us while scoring and while giving up the questions, because yesterday in prelims also we have seen them. So big round of applause to all of them who participated and then who has won and the winners. And we are so grateful to the organizers, Dr. Shwetalina, Abhishek and Dr. Vikas and the whole team who has worked day and night for the success of this conference and who has given us this opportunity to be here in front of you. My sincere gratitude to all the delegates and all of you who are here, who has come early in the morning, keeping aside all your relaxing time and all that, and who have really boosted up our courage and also our enthusiasm. So thank you one and all. Thank you. Yeah, we'll be giving out the participation certificates also, and I think in the valedictory, I think we'll be giving it. So shortly we'll just inform, right? So thank you. We'll go on to the next sessions.
Yeah.
Respect. The quiz masters, kindly receive your memento from the right side of the hall.
Good morning. So may I invite Dr. Survi, additional professor in Department of Pathology, AIIMS. She will be telling and increasing our knowledge on the importance of pathology in leprosy diagnosis. Over to you, madam.
Thank you, ma'am. Actually, this invited guest lecture was to be delivered by Dr. Poonam Prasad Badani, madam, but because of certain reasons, she is not able to come here. So, the whole credit of this PPT goes to her only. So, this talk of importance of pathology, since this whole 1 hour is dedicated to the pathology and immunology aspect, so what I'd like here to say that I will be concised mainly on the basics of histopathology, and let's see what we have things to discuss. So this term leprosy has been derived from the word lepra, which means scaly, and the Hansen word has been given to this disease by the researcher Gerhard Armour Hansen. And this disease is caused by M. leprae, which mainly affects the skin and peripheral nerves. Now, as we will go through this 10 minutes talk, we will see that the complexity of the presentation involves the various immunological responses. Like we have the spectrum in which we will be seeing wherein there are antibody responses and wherein there is cell-mediated immunity. Slowly progressive chronic granulomatous disease is the basic pathology behind, and let's see what clinical and histopathological diagnosis in which cases can be challenging. Before this, may I know how many PG students are here? If they are, then can you please shift in the middle one, because due to this light, I am literally not able to see anyone, whoever is sitting here, because this is more important for you. So if we go to the conventional classification of leprosy, which was given by Ridley Jopling, and this depends on the skin lesion, the bacterial load, and the histology which we see. So it has been divided into tuberculoid, borderline tuberculoid, mid-borderline, borderline lepromatous, and the lepromatous leprosy, which is the conventional, and WHO says that just depending on the amount of the bacilli you have, you can label it as paucibacillary and the multibacillary. So the multibacillary being on the other spectrum of the lepromatous type, and the paucibacillary being in the tuberculoid spectrum. So the basic pathogenesis behind, or we can say the difference behind the tuberculoid and the lepromatous. So the tuberculoid, the clinical responses are determined by genetic predisposition such as association with HLA-DR2 and HLA-DR3. In the tuberculoid form, there is efficient granulomatous macrophage response. So that means that our body's immunity is very high, and there is formation of well-formed granulomas. And as we have read in our Robbins, that granulomas are nothing but the microscopic aggregates of chronic inflammatory cells, in which there are lymphocytes and macrophages, and the tendency of the macrophages to undergo epithelioid transformation. The lymphocytes which are involved here are the T helper cells, that is the Th1 response, and T helper cells dominate over the T suppressor cells. They are characterized by a chronic delayed hypersensitivity reaction. Yeah. Yeah, sure. I request Lakshmi Rajan ma'am to kindly come on the stage to chair the session. Okay. The pathogenesis which is behind the lepromatous lesion is the Th2 response. That is, here the T suppressor cells are more numerous and the interleukin 2 producing cells are scarce. Now this represents a response to prostaglandin, which is peculiar to the cell envelope of the leprosy bacillus. Here the patient's immunity is low and it doesn't have an ability to develop significant T cell mediated hypersensitivity action. So the formation of granulomas is very less here. We are not able to see granulomas in the lepromatous form. So, but the level of antibodies which are found in the lepromatous type Lucio phenomenon, as we'll see later on. So the basic classification that we can see between the two spectrum, that is the paucibacillary and the multibacillary, or the spectrum of tuberculoid to borderline to mid-borderline and lepromatous and borderline lepromatous and the lepromatous is that there is a difference not only in the histopathology. So in the histopathology, we have good well-formed granulomas, presence of epithelioid cells, presence of CD4 T cells in the tuberculoid pole, and the cytokines that are found there is the interferon gamma, interleukin 2, interleukin 12, 17 and TNF alpha, with the predominance of CD4 cells. Whereas in the lepromatous pole, there is more of humoral immunity, as we can see here. There is more of, I don't know how it works. There is more of humoral immunity with high bacterial index, and the cytokines that are involved are different. That is interleukin 4, 5, 10, 22, TGF beta, and FOXP3 cells. That is T regulatory cells are also in the scene. Now coming to the histopathology and the clinical features which help in basic differentiation, that in the tuberculoid form there is very high resistance to the lepra bacillus, and the immune reaction is well mounted. So the clinical features that occurs are localized, single, asymmetrical, truncal or limb lesion, and the lesion is an erythematous plaque with raised margins and flat hypopigmented center. The histopathology that we will find here, that because of very high cell this delayed type of sensitivity reaction and immunity, there are well-formed, large, non-caseating but compact granulomas. So this compactness helps us to see that they are associated with the leprosy. In the tuberculoid form, the Langhans giant cells can be present. The inflammation extends to the epidermis. This is one of the very important differentiating feature from the tuberculoid, and as we go down the spectrum, the involvement of epidermis decreases because we have a very fine grain zone which is present between the epidermis and the dermis. Usually the nerve bundles, because of the granuloma formation, the nerve bundles are not seen well. Acid-fast bacilli can be absent or they can be rarely found. So, so what we can see over here is this is the epidermis, and here the inflammatory cells can be seen lying along the neural bundles, which might require an S100 to be put up so as to identify them. But in the lower diagram, this is one nerve bundle which we can see, and there is very huge this T lymphocytes, which of course when you will do an IHC, you will see that these are the lymphocytes which are surrounding them, and these are the very beautiful giant cells which are seen in this granuloma. Now coming to the borderline tuberculoid leprosy, it has an intermediate presentation, and the presentation that can be seen is that there can be multiple lesions which are asymmetric, flat, hypopigmented, and they can present with the satellite lesions. So how to differentiate between a tuberculoid and a borderline tuberculoid? Now again, in the tuberculoid we have good well-formed granulomas which can be seen here also, but the Langhans giant cells which were seen in the tuberculoid are quite variable. They might not also be seen in the borderline tuberculoid. And granulomas are predominantly seen, and they involve the upper and lower dermis, but the epidermis is uninvolved. Now coming to the mid-borderline. So mid-borderline is the midpoint. So from a very good cell-mediated immunity to a very poor cell-mediated immunity with very less antibodies to high antibody levels, there is a midpoint which is the mid-borderline leprosy. And here we have annular lesions with sharply marginated interior and exterior margins. There are large plaques with islands of clinically normal skin within the plaque, which gives a Swiss cheese appearance. So when we see at the histopathology, of course, there are epithelioid histiocytes, but as opposed to the well-formed compact granulomas which were seen in the tuberculoid pole, here we have not so well-formed distinct granulomas. So we have collection of epithelioid histiocytes, but the compactness will be lost. There will not be any Langhans type giant cells, and the lymphocytes, instead of being a very perivascular or a perineural periadnexal type, they will be present diffusely. And there can be proliferation of the nerve bundles, and from here the bacillary index starts increasing, whereas in the tuberculoid pole or the borderline tuberculoid, the bacilli might not be appreciated. Then coming to the second last spectrum is the borderline lepromatous, wherein the lesions are fewer in number as compared to the lepromatous type, and but there are numerous erythematous skin lesions that lack clear cell borders. So as we saw in the tuberculoid pole that there were very distinct exterior interior margins with the raised margins, but this will not be seen in the case of lepromatous pole. So they are common on the face, extremities and back, and when we see the histopathology, please look very carefully, there is a very Gren zone, that is the area which is devoid of any inflammatory cell just below the epidermis is present. There are aggregates of lymphocytes and macrophages. Here the tendency of the macrophages to convert into epithelioid cells is absent, because of course you need certain cytokines for them to undergo this transformation. And the cytokines are very different. So in this, the bacillary index ranges from 4 to 5, and there is formation of, there are large bacilli which are formed, groups of bacilli. So the last one, that is the lepromatous form, in which there is multiple symmetrical affecting the whole skin, and the lesions form nodular. They become anesthetic due to high neural involvement. In the same way, in the lepromatous leprosy, the Gren zone can be seen. There are sheets of foamy histiocytes, which are also called as Virchow cells. And in this acid-fast bacilli stain, we can see that there are numerous globi which contain these acid-fast Mycobacterium leprae. So there is another form, that is the indeterminate leprosy. And on a lighter note, how do we diagnose indeterminate leprosy? So when the clinician is suspecting leprosy and the pathologist after describing says kindly correlate clinically. So this is one wherein you can have indeterminate leprosy, because we don't find a bacilli, we don't find granulomas, we don't find macrophages which are containing those bacilli. So this can be presumptive diagnosis. Now, although this is the basic pathology which is behind the spectrum, but there are certain reactions which are equally important, for which we need to see that there can be upgrading or the reversal reaction or the downgrading reaction, and there can be in the type 2, which is erythema nodosum leprosum. All these things are inflammatory driven processes. So in between, in the treatment process, if the inflammatory immune capacity of the patient improves, then of course there can be improvement in the immunity, and there can be these kind of upgrading reactions. So in this what we can see that there is type 1 reaction or the reversal reaction. Okay, so I'll concise, like in upgrading reaction, the granuloma becomes more epithelioid. So just remember that in the upgrading form, since the immunity has increased, so these macrophages will undergo an epithelioid transformation, and there will be formation of good granulomas. Whereas in the downgrading type, there can be increase in the density of bacilli. Fibrinoid necrosis, not so common. Why? Because we have another process, that is the Lucio phenomenon, wherein the fibrinoid necrosis, necrotizing vasculitis, and loads of bacilli in the endothelial cells can be seen. So this is ENL. ENL is an immune complex production and deposition, wherein we can see there are macrophages in which there can be fragmented bacilli in the histiocytes and the giant cells, and the predominant cells are the histiocytic infiltrates. Apart from that, in ENL, we can find the neutrophils which are found along the outside the blood vessel wall. So too many neutrophils in the skin, ENL. Then there is another phenomenon, that is the Lucio phenomenon, and in this there is endothelial proliferation, and the acid-fast bacilli will be found in the walls. And since there is necrotizing inflammation, so we have, if we do not have the history of leprosy, or the patient is not taking treatment, so you have many differentials like polyarthritis nodosa, limited DIC. So we have to differentiate in this, but here the bacilli content will be very high. Okay, so this is just a gist of all the reactions, and okay, so this summarizes the whole basic pathology of the lepra reactions and the leprosy poles. Thank you.
Hello, please 1 minute. Thank you for a good presentation. It's very nice, very clear. Thank you once again.
Thank you.
slide. Next slide from here. नहीं, from slide show करना होगा. Next slide, next slide. इससे भी तो हो जाए.
Now we welcome Dr. Lakshmi Rajan Madam. She will be telling on the topic early diagnosis of malignant change in chronic plantar ulcers of leprosy patients. Over to you, ma'am.
Good morning, everybody. I am presenting related to malignancy in plantar ulcers. It's early diagnosis of malignancy in chronic plantar ulcers in leprosy patients. The aim is to diagnose malignancy early to prevent amputations, to prevent secondaries to regional lymph nodes or to other organs. And plantar ulcer is the common complication of anesthetic feet. Malignant transformation can be suspected when it is growing very fast, cauliflower-like growth, irregular everted margins, or when it is bleeding on touch. And during last 5 years in our hospital, 20 to 24, we received 166 ulcer biopsies with suspicion of malignancy from Karigiri surgery department and also from TLM centers. We fix the tissue in 10% formalin, process in semi-automatic tissue processor, paraffin blocks prepared, and 5% 5 micron thick sections were cut for histopathology and stained with hematoxylin diosine. And results we have seen 61 malignant ulcers we diagnosed and 93 non-specific chronic ulcer, and 12 biopsies were inadequate for commenting on malignancy. And 59 squamous cell carcinomas, again, out of 61, 59 are squamous cell carcinoma and 2 are malignant melanoma cases. And 59 squamous cell carcinoma, again classified into well-differentiated squamous cell carcinoma, moderately differentiated, and poorly differentiated. Majority are well-differentiated because it's early stage of the malignancy, and second stage is moderately, and poorly is the final very bad prognosis stage. And well-differentiated means the squamous cells resemble normal squamous cells with areas of infiltration. When they look very normal, it's very difficult to comment on malignancy unless we see areas of malignancy, areas of infiltration, like, it's not coming. Oh. See, these are areas of infiltration. When it is going down into the deeper layers, we call areas of infiltration. But we can see normal squamous cells and squamous pearls also with chronic inflammation around, but it is early malignancy, what we call early well-differentiated squamous cell carcinoma. There's another slide also. Here also we can see squamous pearls and keratin formation plus infiltrated areas of malignant cells. And moderately differentiated squamous cell carcinoma is, we can see atypical cells with hyperchromatic and pleomorphic nuclei and increased mitotic activity. So you can see the keratin production, we can see the squamous pearls, still we can recognize them as squamous cells. And there is a hyperchromatic and pleomorphic nuclei suggestive of malignancy, and there is increased mitotic activity. That means it is growing fast. Higher magnification of the same slide, you can see hyperchromatic nuclei and atypical mitosis. Normally, every living cell divides, but that is normal mitosis. But when we see atypical mitosis, that means when the chromosomes divide irregularly, that we call atypical mitosis, which is suggestive of malignancy. And this is a moderately differentiated, where the cell division is very fast. That means the tumor is growing very fast, and the prognosis is not very good. And this is poorly differentiated. Here, the tumor cells cannot be recognized as squamous cells at all. The cells are large, atypical, with hyperchromatic and pleomorphic nuclei and increased mitotic activity. Here we can't say the cells are squamous cells or not, because they are not producing any keratin, and we won't see any squamous pearls anywhere, and they are malignant cells, highly malignant. You can see the mitotic figures, many mitotic figures are there, very fast growing, and the prognosis is not good. Conclusion, early diagnosis helps to prevent amputations, enables the patient to walk on their own feet, prevents spread to regional lymph nodes or distant organs, and reduce morbidity and promote a better quality of life. See, this is a malignant ulcer, very small, but it is malignant ulcer. And what was done for this patient, we excised the ulcer completely with wide margin here, and then was covered with neurovascular pedicle graft. That surgery was done by our plastic surgeon. Neurovascular pedicle flap. Patient can walk with this. There's no need for amputation for this set of early cases. So we can save the leg and patient can walk with their own feet. As we can see, it's a very late case. The ulcer is too big and we cannot go with any flap or local excision. The patient had a below-knee amputation. And it's growing very fast. When it goes to regional lymph nodes, block dissection has to be done. And so we better not to allow any patient to go to this stage. Already they suffered with leprosy whole of their life. And when they land up in malignancy, it is again trouble for them. Thank you.
Thank you, Dr. Lakshmi. I have a question. Sorry for my ignorance. So you did biopsy of all the plantar ulcers or in cases where you have high suspicion?
Only when there is suspicion.
Okay.
If we do for every case, we will be unnecessarily producing increase, wound will increase unnecessarily if there is no suspicion. Any more questions? Sir? Mic, please.
Hello. Yeah. You differentiated into poorly differentiated, moderately, and well differentiated. So I was just wondering, the morphology of the ulcer, did you make any comparisons with how the original cauliflower growth was with the well differentiated versus the poorly differentiated?
Morphology we cannot make out. Only when we see under the microscope, microscopically only we can classify depending on the atypical cells, increased mitotic activity, hyperchromatism.
Yes, but
like
I'm
that.
interested in also seeing how a clinician, a leprologist, can doubt a cauliflower growth, that this is most likely to be a poorly differentiated requiring a amputation, whereas this differentiated that requires only a wide excision.
It's only pathology only. We cannot say morphologically.
Yes, madam, but I'm just asking if any comparison can be made with how the growth looks at for the clinician to decide whether there would be a wide excision needed or a below knee amputation.
When it grows, when it is not healing, when it is growing fast, we suspect malignancy. That time we can do wide excision and see whether it is well differentiated, poorly differentiated, or in between.
Clinically, when we see some sprouting granulation tissue, we take a biopsy. Sprouting granulation tissue, if the edges are everted and it's sprouting, either one of the two, and then we send it for biopsy. Then they will tell us. Yes, yes. And depending on the duration and the size, I think we can to some extent, maybe it needs to be studied, but we can to some extent correlate whether it will be poorly differentiated, well differentiated or whatever. In the early stages when it is small, usually the result comes as well differentiated. But when it is really huge and big and when there are nodes elsewhere and all that, the result comes back as poorly differentiated. So it's a stage. And sir, to answer your question, Shefflin Institute, where she's working and where I work also, we're a referral center. So that is why chronic ulcers, non-healing ulcers are referred to us. So yes, so yeah. So it's an artificial, it's an artificial incidence or prevalence or whatever you want to call it. Everted. Yes, yes. Thank you.
Yeah, just a word of caution. It need not necessarily be just cauliflower growths. It could be flat lesions which are not healing despite all kinds of measures. I mean, chronic lesions like 5 years, 6 years, and these are flat lesions, non-healing, and they have a slightly different look. They don't have to be cauliflower growths. And they can also be turned to be malignant. And to answer Dr. Sujai's question, some of these flat lesions, which are chronic, tend to be more malignant, either moderately differentiated or poorly differentiated. But it's impossible to make out when it's a cauliflower growth. I just wanted to ask Dr. Lakshmi, during Dr. Job's time and Dr. Desikan's time, they were reporting some of these as pseudoepitheliomatous hyperplasia. Yeah, even Sujai reported. And the only way to make out is pathology, histopathology. So we used to depend a lot on the histopathology report. If it was a pseudoepitheliomatous hyperplasia and it was small and the location was reasonable, and what was done, as you've seen, local excision and either grafting or a local flap can be done. Thank you.
Lymph node involvement sometimes we see, but it's not always because of tumor deposit. It can be due to chronic infection also.
Yes, yes.
Lymph nodes can be involved.
Yeah,
But when lymph node biopsy is done, if there is tumor, then we suggest block dissection for lymph nodes
We
also.
always give a course of antibiotics of 3 weeks, and if the lymph nodes don't subside, even after local treatment, then you will have to consider a block dissection. Thank you.
Thank you.
Thank you so much, Dr. Lakshmi, for your enlightening discussion of chronic plantar ulcer turning into malignancy. Thank you so much.
Ma'am, we'll request you to please be seated for the next session, chairing the next session. Ma'am, please be seated for the next session, chairing. One more session. Yes, ma'am, one more session. We'd like to call Dr. Manuraj S. Sir, final year postgraduate, for the next session.
respected dignitaries on and off dais. In the current context of Mycobacterium leprae trying to shoot down our efforts to achieve the NSP, I hereby present a topic from lens to microscope, histopathological decoding in treatment-naive Hansen's disease. Myself, Dr. Manraj, and let's move on to the topic. As we all know, leprosy is a chronic granulomatous disease caused by Mycobacterium leprae and predominantly affect the skin and peripheral nerves. Despite eliminating leprosy in 2005, India continues to report new cases of leprosy. Accurate classification is essential for correct treatment, prognosis, and prevention of reactions and deformities, especially in case of borderline diseases where clinical diagnosis can be alone insufficient. Because in borderline leprosy, overlapping clinical features happen and clinicopathological discordance is common. There are only few Indian studies in this regard, and hence this study was undertaken to assess the accuracy of clinical diagnosis using histopathology as the gold standard. The primary objective was to study the clinico-histopathological correlation in newly diagnosed leprosy cases attending a tertiary care center. The secondary objectives being analysis of demographic and clinical profile, evaluate slit skin positivity in various clinical types of leprosy. All newly diagnosed leprosy patients attending the dermatology OPD who were not started on multidrug therapy were included in the study, whereas patients who were already on MDT, pregnant and lactating women, children less than 5 years of age were excluded. This was an observational cross-sectional study in the DVL OPD of a tertiary care center for a duration of 1 year from 2024 May to 2025 April. And the sampling was by consecutive sampling. Detailed history and clinical examination was done in all cases. Classification was done based on Ridley-Joplin classification clinical criteria. Slit skin smear examination for AFB and skin biopsy from the representative lesion was taken. Histopathological examination using H&E and Phytopharmaco staining done, and correlation of clinical diagnosis with histopathological diagnosis done. Out of the 50 patients who enrolled, predominantly it was male patients accounting to 58%, that is 29 cases, whereas 21 were females accounting to 42%. The highest age group that presented with the symptoms were among 31 to 40 years of age group accounting to 13 cases, followed by 21 to 30 age accounting to 11 cases, whereas least number was seen less than 10 year accounting to 1 case out of the 50 cases that we received. In our study, the farmers were the highest population accounting for 15 cases, 9 were housewives, 8 each were student and manual laborers, and 3 were unemployed, 2 each were electrician, mechanic, auto driver, and 1 was a professional. The chief complaint was red raised lesion in 58% of the patients, whereas in 36% it was light colored lesions, and sensory loss accounted for chief complaint in 6% of the patients. The distribution of lesions on examination, in 60% of the patients, multiple sites were involved, which was followed by upper limb in 16% patients, 14% in lower limb, trunk and head and neck accounted for 6% and 4% respectively. The clinical diagnosis was done based on Ridley-Joplin clinical criteria, and it was found that the most common spectrum was borderline tuberculoid spectrum, which accounted for 24 cases out of the total 50, giving a 48%. Whereas it was followed by lepromatous leprosy, that is 24%, accounting for 12 cases, followed by borderline lepromatous, mid-borderline, tuberculoid, and mid-borderline. And histopathological diagnosis was done, and in histopathological diagnosis also, the most common spectrum was the borderline tuberculoid, that accounts for 19 cases out of the 50, followed by lepromatous leprosy, that is 14 cases. And here we can see that it was highest, the 38% in borderline tuberculoid, followed by lepromatous leprosy, 28%, borderline lepromatous, 16%, borderline 10%, and tuberculoid, 8%. And clinical histopathological correlation was assessed, and here we can see out of the 5 cases which was clinically diagnosed as tuberculoid leprosy, 4 were tuberculoid and 1 was borderline tuberculoid on histopathology. Out of the 24 cases of borderline tuberculoid, 17 were histopathologically borderline tuberculoid, whereas 4 were mid-borderline and 3 were borderline lepromatous. Similarly, out of 3 diagnosed mid-borderline clinical cases, 1 each were borderline tuberculoid, mid-borderline and borderline lepromatous on histopathology. In borderline lepromatous leprosy, 3 were borderline lepromatous and 3 were lepromatous leprosy. And finally, out of the 12 clinically diagnosed LL cases, 11 were LL and 1 was BL. Overall concordance of 72% was there, and highest concordance was seen in polar ends with lepromatous leprosy showing 91.7% of concordance and tuberculoid poll showing 80%. Whereas the least concordance was seen in mid-borderline group accounting only for 33.3%. Slit skin smear was done for all cases, and it was seen that the positivity increases gradually from the tuberculoid to lepromatous poll. And here we can see that in the mid-borderline, borderline lepromatous and lepromatous poll, 100% of the patients had positivity for slit skin smear. Whereas in tuberculoid spectrum, in TT poll, no patients were positive for slit skin smear, and in BT, 5 out of 25 were positive. And the positivity also increased. In BT it was 1+, BB it was 2+ to 3+, in BL it was 3+, and in LL it was 4+ to 5+. The male predominance was seen in our study, and peak incidence was seen in young adults, similar to the previous Indian studies. And the national strategic plan amounts to have zero transmission of leprosy by 2027. But the ongoing incident cases, especially in young adults, suggest the increased transmission in the country, and this can impede the successful implementation of NSP. To conclude, de novo cases, despite elimination, calls for stringent case diagnosis and early treatment. Incidence in young adult is a risk for high transmission. Histopathology will be a favorable tool to value essential for accurate classification. Clinically overlapping borderline forms will be classified accurately based on histopathology and will help to prevent the complication transmission by accurate treatment. My study was limited, being a single-centric study and inter-observation variation in histopathology. These are my references. Thank you.
Thank you, doctor, for a good presentation. Have you ever seen histoid leprosy also when you were doing study?
Histoid leprosy cases were not enrolled, ma'am. During the study period, we didn't get any histoid leprosy cases, ma'am.
Okay,
clinically or histopathologically, we didn't have any cases.
It's okay. Thank you.
Thank you.
Thank you to all the presenters for enriching this session. I request you to kindly receive your memento. We also thank our chairpersons. We now move to the much anticipated panel discussion on applied aspects of immunology and with implications for diagnosis and therapy. I now invite our moderator, Dr. Gaurav Das sir, Assistant Professor, Department of Dermatology, AIIMS Patna, to kindly lead the session. I also request our esteemed panelist, Dr. Itu Singh ma'am, Dr. S.K. Tripathi sir, Dr. Pooja Agarwal ma'am, Dr. J.P. Swan sir, Dr. Rashmi Singh ma'am, Dr. Aditi Snehal ma'am, Dr. Dipendra Timshina sir, to kindly take their seat on the dais.
I would also like to call upon Dr. Sandeep Chaitanya for the panel discussion. Kindly come to the dais. Dr. Rashmi Singh ma'am. Dr. Dipendra Timsina, Dr. Aditi, not there. Okay. Dr. S.K. Tripathi. So, good morning everyone. We are here at the panel discussion, basically on the applied aspect of immunology with implication for diagnosis and treatment. It is a very advanced and new treatment. So we'll try to discuss our panelist experience and new things about this subject, which is the upcoming one. As you all know, immunotherapy is basically used as adjunct to MDT to correct the host response. Primary thing is to rapid killing, clearance, and reduction in severity. Mechanism, I think you all know. These are the mechanism of action, increase the immunity. These are the vaccines. These are the prominent vaccines, I think you all know. So we'll go directly to the questions to my panelists. What are your indications for immunotherapy in your practice? Sir, ma'am, anybody can start. What are your indications, ma'am? Sir, ma'am?
So any patient towards the lepromatous fold, be it BL or LL with a high BI, we try to induct them into the immunotherapy protocol, or a patient with recurrent ENL. So that is how we treat at our institute.
Okay. Any other panelist?
Actually,
Dr.
sir,
Jyoti sir, Dr. Rasmi ma'am?
when the BI is more high and it is not reducing after giving MDT also, 6 months or 12 months, then only we also start BCG. MIB, so it's not available in our center. So we start
Little mic, sir.
we start BCG
Yes, sir.
every 3 monthly, quarterly or 6 monthly, sir.
Any other indications, ma'am? And you can also share your experiences with BCG or MIP if you are used in your practice. Which cases do you prefer?
Actually, I prescribe this immunotherapy. I add on this therapy when the patient has relapse, or sometimes also in the reaction cases, type 2 reactions. BCG is the one which I have used, and it has shown good results. I have not seen that PB cases which have been reported in case of BCG use.
Yes, ma'am. Sir, Sandeep sir. Any experiences, sir?
Can you hear me? Yeah, I'm not a clinician, but what I have read through in different reports is that persistent high BI is always a challenge, and having to use some of these adjuvant immunotherapies, adjunct immunotherapies, along with routine MDT may provide additional sort of influence on reducing the bacterial load quickly. That's been the thought around MIP at least, but we don't have any information like that for Lepvax yet because it's still in trials, still in phase 1A, which has cleared safety as of now. That's it. So yeah, I think it would definitely contribute to reducing the bacterial index if we add it along with MDT. That's the current understanding.
Any role of immunotherapy in reactions? Anybody would like to tell? Dr. Ritu ma'am?
Definitely, sir.
Because high load, bacillary load is definitely an indication.
Yeah, and second thing, during reactions, in high PI cases, if MIP is given, it has been reported that chances of occurrence of reaction has been reduced. And in type 2 reactions also, as Dr. Pooja already mentioned, that it easily dissolve the reaction in helping the reaction subsidence.
Yes, ma'am. Thank you, ma'am. So actually, as ma'am said, we have experience with BCG. We have also been using BCG in our institute, our department. There have been decent results with it. We have not used MIP till now. So basic primary indication, as we have all talked about, basically the first point I think I already covered, high bacillary index, LL and BL pole, the persisters, and usually we can shorten the treatment with MDT and chronic recalcitrant ENL cases which doesn't respond to the standard MDT. And there have been few studies which have found to be having a reduction in time duration for like the MIP vaccines. It has been seen here. There will be shortened duration of treatment with it. And head-to-head-on trial is there. Some trials having showing BCG is better than MW, and some are showing MIP is better than BCG. South trial had found that IRCT and this a BCG plus killed vaccine having a good protective action. Lepvax is a upcoming vaccine which has been used. Coming to the case scenarios, case 1 and case 2 I'll talk about. Case 1 having, this is a 45-year-old female having completed 1 year of MDT, but still new lesions are still appearing, and we did a slit skin smear and it was 6+ and morphological index 80%. And this one is also after 2 years of MDT, this male patient having infiltration still persisting. Similarly here also slit skin 6+ and MI 20%. I think you all might be facing this kind of challenges in your practice after 1 year or 2 years of MDT, still it is there. So what is your approach in these cases as a clinician and also as a testing point of view. Sir, anything, sir, madam, anything you'd like to add?
Sir, in past
How will
case,
you approach? Yes, sir.
In past case, definitely we can think of rifampicin resistance or antimicrobial resistance. So for that, if there is center is available nearby and if there is possibility, you can send for test, AMR test. Otherwise, we can add along with MDT because it is only 1 year. So second line bactericidal, mostly I prefer moxifloxacin or clarithromycin.
So you use regularly, sir?
Yes, sir, I use.
Moxifloxacin.
Yes, whenever it,
Yes,
after 1 year, if it is more than MI 80%, BI is not reducing. Along
Yes,
with second line, then I give also BCG.
Yes, ma'am. Anything you'd like to add?
So in both the cases, what I would like to re-emphasize is like it was discussed yesterday that leprosy is not something which is very static, that this fixed duration is needed for treatment like we earlier used to read. It's a very dynamic thing which we decide on the treatment on a day-to-day basis. We do regularly come across cases where patients have finished 1 year of MDT or 2 years of MDT, still they're getting new lesions or infiltration is there. My approach would be to first check for antimicrobial resistance, as sir has said. Unfortunately, we have very few labs across India which are doing that, so that is one of the limiting factors. And going on to second line therapy, we prefer clarithromycin, clofine, mino at our center for that.
Okay. And if resistance is not available, any drug you give, ma'am, you told? Any drug you add after, suppose this second case is 2 years of MDT completed, which is your drug of choice you prefer?
So we add here clarithromycin, clofazimine and minocycline regime.
Yes,
we don't go for Oflox or moxiflox.
Yes,
Sir, in this case, case 2, already 24 months already MDT he has taken. We can switch over, even if AMR test is not available, we can give RCM or RMM therapy.
Okay, monthly one.
Yes, sir.
Yes, sir. Rome regimen, RMM. Yes,
RCM
yes,
or RMM. Rifampicin, clarithromycin, mino, or rifampicin, moxifloxacin, mino.
Yes, sir.
Yes, sir.
Ma'am, anything you like to add?
Yes, I agree. Actually, initially we used ofloxacin, but somehow the resistance is developing and the patient keeps to have those lesions. Lesions keep coming in spite of ofloxacin, so we switched to clarithromycin or the other minocycline.
Yeah, actually we also are facing these challenges. Many patients are coming with this kind of scenarios and we are regularly actually sending our patients for resistance testing. Dr. Itu ma'am and Sandeep sir, can you elaborate on the resistance testing which we can do here?
Yeah.
Yes sir, you can add sir. Yes sir, definitely. Yes. Mike. Yes, sir. Yes, sir.
It's working, but it will be under trial, Lepvax.
Can you say it again?
Lepvax.
Lepvax.
Lepvax has been used,
Yes,
Sandeep?
let me respond, sir. They have cleared phase 1A, which is a safety trial in humans.
Stage 2 trial, that's what I'm telling. It has not been,
yes, sir.
General mass, it has not come in at all.
No.
Other things are available. It will come in market later when there is no trial is over. So it has not been used for use now. Second is, when there is a reactions, you are telling that it will end up in reactions, okay?
Yes, sir.
Before that, you should, as suggested, you should look for resistance first and
Yes,
go for second line drug. I agree with that.
Yeah, for starting the second line drug, I would suggest that first do the AMR testing and then you start that.
Before going for
because many areas it is not available. That's why
Even the age of Chhattisgarh, it is not possible.
that is the only issue.
In periphery, we have so many patients in our college.
Yes,
I
yes, ma'am.
can tell you that every day we are seeing 4 to 5 patients are minimum we are seeing in leprosy, and all MB cases we are seeing with full-fledged LL lesions, and we are not able to do the resistance testing in spite that they are not responding to 1 year of MDT. We have no choice.
That is the ideal scenario, but unfortunately we have to make do with what we have.
Yes.
Yeah, I
Yes,
agree.
ma'am.
But whenever we'll end up with the second line drugs resistance, then it will create a havoc in leprosy
A
conditions
few of the
because we
studies
don't
also have
have
found like that also.
other drugs for
Actually, madam, in tribal state like Chhattisgarh, it is not possible for AMR.
Yeah, actually, sir, what sir is telling, we were also facing the same thing before our postgraduate then started a thesis on this. Then we sent the testing to ma'am only, and after that we routinely send this antibiotic resistance testing. Otherwise, we didn't have any amenities that time. So we, as madam also told, we are also added the therapy after 2 years of MDT ofloxacin. That therapy, according to WHO, we were adding without doing testing. But now it is available. We are sending if patient agrees to that. Thank you, ma'am. So basic, yes, ma'am. Yes, sir.
No, if it's not interruption, see there are two issues here. One is that non-response. Non-response after 1 year,
yes.
And I think this case non-response after 2 years.
Yes.
And second is resistance. Let us not confuse between those two.
Yes, sir.
The patient is not responding, there can be various reasons. So I think we have to evaluate the patient whether it is non-response. So just because non-response is there after 2 years and you are unable to do resistance testing, doesn't mean that you should start second line 18 months or 24 months course, which is only valid for rifampicin resistance is proven. Without proving rifampicin resistance, please do not start
second line therapy.
Second
Yes,
line,
sir. Exactly.
second line means arsen resistant therapy.
Yes, sir.
That is exclusively for that. But otherwise, please look at the causes for non-response. See, if you are looking at general medicine, suppose somebody has anemia and we give iron and supplements and is still not responding. There is a protocol how to evaluate a non-responsive case. Even in leprosy also, because you are all young doctors and dermatologists qualified, please evaluate why he is not responding. It is not necessarily that we should go for 24 months duration, every month course which is for rifampicin resistance. Thank you.
Sir, can I ask one thing?
Thank
that,
you, sir.
In this scenario, can BCG can be given to the
Yes,
patient?
BCG can be given, maybe MIP can be given.
Yeah.
Yeah, maybe just look whether the patient is taking correct drugs,
Hmm.
dosage, whether he is compliant. Maybe you should continue MDT for 1 more year, how much he has taken. So those reactions are happening, maybe intercurrent infections are happening. Maybe he is on steroids, that is the reason he is not responding. So various reasons could be there.
So instead of giving the second line drug, it will be better to give the immunotherapy.
No, one thing, ma'am, for everybody, they are not called second line drugs. They are called drugs in the case of proven rifampicin resistance. There are no second line drugs or second line MDT regimen available as of now. It's only available for rifampicin resistance cases. That's it. So right now we have MDT and one drug regimen for rifampicin resistance. In between we don't have anything else. It is time young dermatologists like you take up a protocol study and say which regimen can be used for in such cases and then follow it up and come out and publish and come out with evidence. So that, like for example, ROM therapy was mentioned. So we can give ROM every month. Yes, but please conduct a study to evaluate it so that others can follow you or you yourself can refute it or find it beneficial. Thank you.
Thank you, sir. So basically resistance, I think you all know 2 types. Primary resistance, it will not respond. Secondary, after relapse or inadequate therapy. These are the mechanisms as you all know. And these are the standard antimicrobial resistant therapy. The PCR is the standard one now. And few of the systematic reviews I'll go through. They have found a standard drug resistance at 10%. And these are nominal other drugs resistance. Few of them have found, as madam already told, that second line drug like ofloxacin, there is been more resistant, but the standard is responding. It is actually regional variation. Somewhere in north they are finding some resistance, primary is more, but some having 0 first line drug resistance. There is no resistance. MDT is responding wonderfully in some of these studies. This is a study in the south, Andhra Pradesh. They have found no resistance. And some are having high primary resistance And basically resistance as one of the indication previously discussed, the chronic or recurrent ENL also resistance has been found. And this is the largest study done, and many similar testing has been done. Treatment, as sir was telling, dapsone resistance you should follow the standard MDT regimen, but rifampicin resistance you have to follow this regimen, 6-18 month regimen. This is some of the cases in our AIIMS. One postgraduate is doing thesis under Svetlana madam, and these are some of the cases we had done rifampicin and this other MDT drug testing. Now coming to the next thing, this is chemoprophylaxis. We'll talk about what are the indications of your chemoprophylaxis or immunoprophylaxis, drug of choice and experiences. Where do you use?
Then in case of, as far as chemoprophylaxis is concerned, I actually, as we all give rifampicin that we have been using.
Single dose rifampicin.
Yes, single dose. But few cases what I am seeing is if they are the multibacillary cases, the index cases are multibacillary. The contacts in that case may again develop the lesions in spite of giving a single dose regimen. I have seen that. Yes. So in such cases we should add rifampicin. We should add rifampicin in the subsequent months, like 3 months or 6 months. We have to decide on something like that.
Yes, ma'am. So, ma'am, anything you would like to add?
And 6+, 5+ index cases are there. So we give sometimes. I have given only 2-3 families till now.
Yes, sir. So basically these are the contacts, but as madam told, household contact sometimes don't respond. There has been in studies are there. These are the high risk people, they also can be given. And rifampicin, dapsone is not that much used. Combined regimen they have been used. As sir previously told that to cover this the single dose regimen not effective in close contacts, as madam already told, to overcome this enhanced bactericidal drugs have been added. That is rifampicin and clarithromycin, to give a long lasting effect and better result. And immunoprophylaxis with the vaccine we can add the BCG vaccine alone, it is more effective. Combination of BCG is not that, it is almost the same thing. BCG, as you all know, it is a varied response protection, 20 to 80% it has been found in the studies, and it is more among the contacts. Here also you can see in the meta-analysis published, varying degree 20 to 80%. MIP has been showing good protective around 70%, but still more studies should be done. So this study also concluded by author that combining both is a better strategy. And basically healthy contacts also we have to give, and it is basically safe and very easy to use. Coming to the third case, this is a 40-year-old having recurrent ENL. This is also completed MDT 2 years. So what is your approach? Anything different? How do you manage these cases?
Addition of immunosuppressive agents is the one which we do.
Which one?
In fact, in our case. In case of
along with steroid?
Yes, besides steroids.
Yes.
Steroids we have to taper at some time, that yes, we all know. So we have to add some immunosuppressives if the patient is still, whenever we are trying to reduce or taper the dose of steroid and the patient starts to have the ENL lesions, then we have to add some kind of immunosuppressives. Most commonly in periphery we use methotrexate because of the cost issues, and other like JAK inhibitors, that too I have tried and it works well.
Yeah, many patient comes with relapse or recurrence of ENL after the stoppage of the lower strength of drug, like that is 10 milligram or 5 milligram, they recur again with MDT. So any other panel should like to add any regarding medication sparing? Yes, yes.
I add thalidomide here along with steroids and continue clofazimine because it has both an anti-inflammatory action and some amount of anti-leprosy action also.
Clofazimine doses, ma'am? Doses?
50 mg daily. Clofazimine. No, I have not used tofacitinib or any other drug. Sometimes I have used methotrexate or azurant, but that also very rarely because these cases I have seen they do very well on thalidomide. So maybe I have been lucky in that aspect.
Okay. So this is also found resistance to rifampicin, and guideline also tells that we should do also involve leprosy reactions also to this antibiotic, as everybody told here that antiviral resistance should be done in these cases. So this question, the new serological and molecular testings, what are the advances? Dr. Itu ma'am, Dr. Sandeep sir, can add anything? Apart from the usual, what new things and which has been added in practice and which are in pipeline like that?
Like regarding molecular test, field-friendly test is in the pipeline. Validation is going on. TrueNet with the TrueNet machine, and it is made in India. And from the Sandeep group, I think Biennial is in the pipeline. And regarding serological tests, there are many tests available, field-friendly also. But for the diagnosis of PB is the
It is a
real
challenge.
for the use
Still
of
a challenge, a grey area in
yeah.
leprosy. Yes, sir. Sir, anything you'd like to add?
Yeah, I think just add to what Madam said, there are newer targets as well for drug resistance.
You had presented a good presentation, sir, on this
thank,
also.
No, thank
Yes,
you very
sir.
much. Yeah. So there are new targets. So one of the study we are doing in the Philippines is looking at 9 targets instead of just 3 for drug resistance. So there are compensatory and co-occurring mutations that we are recognizing in genes that are indirectly involved in the mechanisms of antimicrobial resistance to 3 drugs in MDT. So, of course, 2 drugs plus ofloxacin. So, having to have that sort of a panel of 9 genes together screened would be advantageous. And second good experience we had with our work with Karigiri is to use Minayon to amplify the targets. Minayon, Oxford Nanopore Minayon sequencer, which is sort of compatible sequencer that could be used in a clinical setting where some basic laboratory facilities are available. So we managed to sort of bring about a good correlation between the standard sequencing of genes and the Minayon sequencing. So having to adopt to technologies that could easily be taken, I wouldn't say to the periphery, but at least to the regional hospitals in states like Chhattisgarh or somewhere would be helpful, rather than saying that access to AMR testing is not there, because WHO insists that the guidelines exist and they insist that testing should be done, especially for case 1 and 2 that you have shown. AMR testing should be done before any clinical decision is made. Yeah. Just wanted to add.
So last thing, any advances in therapy, any new therapy like Madam told, tofacitinib we've been using in ENL, anything new you are using in your practice or any test diagnosis which will be helpful for this audience, any advances to take away from this?
There were 2 trials going on, one in bedaquiline, one is with bedaquiline, you might know,
yes,
and the other one is tilacibec. I'm not seeing anyone talking about it much here. Tilacibec is a drug that acts against the BCCA3 complex, oxidase complex in mycobacteria. It was originally designed for TB, but then it failed working in tuberculosis because TB had another alternative pathway. So that pathway is absent in leprae. So there's a promise. Early work on mice foot patch has shown very promising results from NHDP. So the trial has been initiated just recently, a few months ago in a couple of countries. Could be a promising drug, but it's available now to be used actually. Tilacibec,
yes,
Q203.
So, as my panelists have already told, any of my learned audience want to add anything, any new drug in this resistant relapsing cases you have been using regularly in your practice and finding good result, any studies like that? It will be helpful for the takeaway for the audience.
Hello.
Sir.
I have given a talk yesterday about the new drugs, probably Hall B, so very few people are there. So we have discussed about the new drugs, trial is going on. So I just want to give a comment about the recurrent ENL reaction with BA positivity recurrent. That's also, yesterday there is a paper on MIP vaccine in ENL reaction also, that our postgraduate students gave a talk yesterday. So we are giving good, the most idea we have to send for resistance study, very, very important. If the day after RA release from treatment, if the patient is getting ENL reaction, patient should be, the sample should be taken for resistance studies. So accordingly, already WHO has a guideline whenever we develop resistance, what type of treatment should be given. And MIP vaccine has a great role. We have found about 10 case series, we find almost all cases we could able to taper up prednisolone and thalidomide quickly after 3 doses of MIP vaccine. Because what is happening actually in reaction develop because of accumulation of lot of antigens in the macrophage. You have to clear the antigens from the macrophage. Immunosuppression is not important. Important how to clear the antigens, dead bacilli from the macrophage. That is through immunomodulator, not by further immunosuppressing, by giving other immunosuppressants. So most ideal thing, immune complex reaction to manage, you have to give a immunomodulator, don't suppress further the immunity. That's my talk. And if at all the resistance is there, then you have to give newer drugs as per the WHO guideline. They have already, WHO has given a guideline, whatever, if information resistance that Dr. Gaurav has already shown in the PPT, so that we should follow. The Rome regimen and Rome regimen already is there established. WHO has given guideline. If there is clofazimine is not acceptable, pigmentation is there, you can give Rome regimen for 24 months, pulse regimen. That's also quite good, almost equivalent to 12 months of MDT.
Thank you, sir. Thank you. So basically, this is still a gray area in leprosy. Diagnostic and therapy is still difficult. Novel therapies, advances, I think you have all talked about. The PGL, I think you all know, the lead NDO therapy, they increase the detection rate, sensitivity, subclinical infection it will indicate, and also a reliable monitoring for efficacy of MDT. But problem is that they are the markers for exposures, but not necessarily infection. And these are the few breakthroughs as everyone talked about. The ML flow test, rapid test have been developed. And in molecular testing, this PCR, the common gene, RLEP gene, and basically it is helpful in subclinical infection or paucibacillary, but still it is in work. And also resistance, it has been extensively used. These are the list for target and these types of PCR which has been used. Advantages, I think you all know, early detection, and it will be helping in screening. And these are the kits or testing, portable devices, LAMP, BioIN, I think all we have talked about. Some studies are there, and still limitation is there that it is unable to detect all cases of BV. So thank you everyone, thank you panelists, and thank you my audience for enriching the session. Thank you everyone.
Thank you so much, sir, for this engaging and insightful discussion. And thank you all the panelists, sirs and ma'am, for the session. And we'll also request you to collect the mementos at the memento collecting desk. And also, we will now move on to the next session, which is the reviewing progress, reconstructive surgery and rehabilitation. And for this session, may I now respectfully invite our chairpersons for this session, Dr. Mannam Ebenezer, sir, Director Global Program Leprosy, Mission 2 and Leprosy Program Ireland, Dr. Helen Roberts, ma'am, Leprosy Mission Trust India, and Dr. S. Mishra, sir, for this session. Thank you.
Welcome to this reconstructive surgery and rehabilitation session. We are reviewing progress, and I think we have the first talk by Dr. Anant Reddy. Thank you.
Good morning to all. Good morning to Chairman, other sir and madams and all that. I'm Dr. Antretti, representing from Sivananda Rehabilitation Home from Hyderabad. To start with, our primary duty is to prevent the need for the surgery. The surgeon is a skilled firefighter, bravely saving what remains from the blaze. As a dermatologist and IAL members, our role must be that of the fire marshals, conducting inspections, that is nerve function assessment, installing alarms, that is self-care training, and putting out small fires reactions before they become inference. Please remember, surgery is a rescue medicine. Our clinic practice must be preventive medicine. The current practice has gaps, which is we notice in our area is inadequate recognition of early neuritis, delay in initiating steroid therapy, limited confidence in nerve assessment, irregular monitoring of nerve function, lack of standardized referral protocols. The impact of delayed diagnosis and its consequences are progression to irreversible nerve damage, increased deformities and disabilities, higher treatment cost, prolonged morbidity, reduced quality of life of a patient. The epidemiological perspective, a little bit. Childhood leprosy reflects ongoing transmission. Around 4.68% of the new leprosy cases detected in India during 24-25 were children under 15 years of age, etc., etc. Children of leprosy affected persons are at higher risk due to close contact exposure, socioeconomic vulnerability, delayed health seek behavior. Spectrum of deformities in children, in the upper limb, ulnar nerve, intrinsic paralysis, that is clawing, median nerve, thin nerve wasting, and loss of opposition, radial nerve, waist drop is very, very less common. And in the lower limb, common peroneal nerve, it's a foot drop, posterior tibial nerve, plantar anesthesia, and leading to ulcer, cranial nerve, it's a facial nerve, ophthalmos. When to refer for reconstructive surgery in children for leprosy, has many definitions, but as a dermatologist, as a clinical practitioner, at least if we follow these things, that's always better. Child with leprosy-related nerve damage, yes or no? No, continue MDT. If yes, if there is an active reaction, neuritis, then if yes or no, yes, treat medically, reassess later, no, stable for, see for it is stabilized for 6 months. If it is stable for 6 months and more, is there any functional deficit assessed, difficulty in writing, grasping, foot drops affecting gait, recurrent plantar ulcers, ophthalmos, progressive deformity, yes or no? If no, physiotherapy splinting, if yes, next step. Is deformity mobile, positively correctable? Yes, early referral, that is ideal. No, fixed deformities, complex reconstructive surgery. If urgent referral, if non-healing ulcer more than 6 weeks, recurrent ulcer despite MCR footwear, progressive ophthalmos, severe psychological impact. And usually at our center, we do the reconstructive surgery with which have a low but not necessarily negative. Principles of reconstructive surgery in growing children: restore function, not merely cosmetic correction, prefer dynamic positions over static corrections, preserve growth plates and joints mobility, avoid overcorrection, plan for long-term follow-up. Surgical options for upper limb, claw hand, that is FDS four-tail tendon transfer, and Jens-Coley procedure, ulnar palsy, branch transfer modification, thumb opposition, appendiceplasty, contractions, soft tissue release, expected outcomes, improved grip strength, functional grasp, enhanced independency. Surgical options for lower limb foot drop, tibialis posterior transfers, intraosseous route or circumtibial route we prefer circumtibial route, clautos, flexor to extensor transfer, IP joint stabilization. Management of logotomies, temporalis muscle transfer, that's a dynamic, lateral transferophy protective. Objectives here is corneal protection, prevention of visual loss. Preoperative rehabilitation protocol, immediate phase 0 to 3 weeks, protective splinting, edema control, intermediate phase gradual mobilization, muscle re-education, late phase strengthening, functional training, sensory education. Expected outcomes, improve grip strength, functional grasp, correction of claw angle, school reintegration, quality of life improves, enhanced independence. The hand that returned to school. A 15-year-old girl presented with bilateral mobile clawing and marked intensing muscle wasting. Her joints were supple. She could not hold a book properly. She avoided going to school. She was academically bright, but limited by her hands. We preferred an FDS four-tail tendon transfer. 6 months later, she walked into the physiotherapy department carrying her notebook. She opened it and showed a book with her hand. The moment reminded me, reconstructive surgery is not a cosmetic. It restores participation, it restores confidence, it restores childhood. The writing hand. I saw a 15-year-old boy who had a bilateral mobile clawing and intestine wasting. He could not hold a pen properly. He avoided writing in class. Academically bright, but functionally limited. We preferred a two-tail apnoplasty transfer after ensuring stable nerve function. 6 months later, he returned to the Sivananda carrying his notebook. He showed me his handwriting. That moment reminded me, reconstructive surgery is not a cosmetic, it restores participation. A walking child and a 11-year-old boy with foot drop walked with a high stepping gait, no fixed deformity yet. This is the window of opportunity. We performed tibialis posterior transfer through the circumtibial route, 8 months later, walking confidently. Early intervention prevents a lifetime of orthotic dependence. The eye that recovered without surgery. A young adult was brought to our hospital with a lagophthalmos. On examination, he has incomplete eye closure. Importantly, this was of recent origin. We initiated conservative management, systematic corticosteroids, eye care with lubricants, facial muscle exercises, electric stimulation therapy, strict follow-up monitoring. Over the next few weeks, improvement was gradual, but definite. Eye close improved. Eventually, he achieved functional recovery without surgical concerns. Recurrent plantar ulcer managed with surgical reconstruction. A 14-year-old boy, child of leprosy affected father, present with a 3-year history of recurrent plantar ulcer, posterior tibial nerve palsy, complete plantar anesthesia, collapsed medial arch, repeated dressings with temporary healing. Despite customized MCR footwear, ulcer recurrence persisted due to underlying bony prominences and scary instability. Management included surgical debridement, excision of unstable scar tissue, local rotation flap coverage, postoperative offloading protocol, custom modified footwear. At 1 year follow-up, no ulcer recurrence, stable plantar surface, resumed full school activity. Recurrent ulcers require structural correction, not repeated dressings alone. A 14-year-old boy who lost his schooling. When this 14-year-old boy first came to us, he did not complain of pain. That was the problem. An anesthetic foot had allowed a small wound to progress into a deep infected plantar ulcer silently. By the time he reached us, walking was difficult, school had become impossible. For 2 years, he stayed at home, not because he lacked intelligence, but because he lacked wound care. We performed through debridement and regular dressings. Gradually, healthy granulation tissue developed, a full thickness skin graft was done, and it took beautifully. But the real success was not the graft, it was what happened afterwards. With productive footwear and self-care training, he walked back into the school, tailor, confidence, smiling. We did not just close an ulcer. Surgery reopened the doors to his education and his future. Psychological changes in a child after reconstructive surgery, improved self-care, better body image, increased participation, improved peer interaction, reduced feelings, greater independence, hope of future education and employment. Challenges in the clinical practice, late referral for surgery, fear of surgery in patients, financial limitations, irregular follow-up, limited trained reconstructive surgeon. A 10 years follow-up here. Key take-home messages is childhood disability reflects delayed detection, early nerve assessment prevents a deformity, reconstructive surgery is restored function and dignity, structural rehabilitation is mandatory, multidisciplinary approach ensures sustained outcomes. Timing decides the scalpel. Every mobile claw that becomes fixed, every ulcer that becomes chronic, every eye that lost protection represents a missed window. As a dermatologist and leprosy physicians, we are the first point of contact. Our vigilance determines whether a child needs corticosteroids or a scalpel. Reconstructive surgery restores function, rehabilitation sustains it, but early detection prevents it. If we act in time, we do not merely correct deformities, we protect childhood itself. Thank you.
Thank you, Dr. Anand Reddy, for an excellent presentation. I'll allow one or two questions if they are there. Yes, Dr. Pai. No, I'm not sure. Dr. Karmi. Please pass the mic on to him.
Good morning to all of you. I am Dr. Karmi, SLO, Odisha. Also doing reconstructive surgery. I would like to ask, in simple chronic ulcer in children, what is the minimum time required without surgery, only by splinting for healing?
Dr. Anand Reddy, do you want to answer?
I can't hear properly.
Okay. You are saying it's no different from an adult.
Without surgery?
Yeah, without surgery.
Only,
if you have a simple
splinting,
ulcer, if you either put him in an offloading device,
yes,
or you put him in a plaster of Paris cast,
yes,
if it's a 4-foot ulcer, it should heal within 3 weeks.
3 weeks.
And if it's a heel ulcer or a lateral border ulcer, it should heal within 5 to 6 weeks. It's no different between children and adults. They may heal a little faster. But we normally put them in either offloading device or plaster of Paris for 3 weeks. And by that time, you usually find that it is healed.
Thank you, sir. Another question. If the ulcer recurs after 6 months or 1 year, if that ulcer again recurs after 6 months or 1 year, then what is the procedure? Should you go for flap surgery or any reconstructive surgery for that, or again we can repeat that procedure?
If you have the provision of a plastic surgeon and he can do a sensate flap, which is not possible usually, but if sensate flap is possible, that's the way forward. But otherwise, you can again put him in a plaster or an offloading device and it will heal.
Third question, sir.
Yes.
Is there any specific type of dressing for these ulcer patients?
No.
Is there any specific or only cleaning and putting any antibiotic ointment available?
No. The only answer to healing of plantar ulcers is offloading. Any dressing you use may make a marginal difference of 1 or 2 days in the time to heal. But if you have a Pseudomonas pyocynia infection, you may want to use acetic acid dressings. But if you are dealing with a complicated ulcer with a lot of slough, you may want to use a Dakin solution so that the slough separates and you can easily remove it. But otherwise, it is any dressing would do, as long as it's a clean, sterile dressing.
Is there any preferable antibiotic for this?
Last question.
Yes, sir. Is there any preferable antibiotic for these cases?
No, it depends on if you have culture and sensitivity report, that's fine. Otherwise, you'll have to go with the local, locally what is the antibiotic working against these organisms.
Only last question, sir. If the ulcer is very much chronic, because we are facing this. Before coming to state, I was a the district leprosy officer, and I was taking care of the colony patients. So I am closely associated with this, and I have faced this problem. That's why I am asking. If the ulcer is very much chronic, years together, should we go for biopsy?
It depends. It depends on what are the clinical signs. Does it look suspicious? Does it look a little bluish or slightly different at the edges? It purely depends on your clinical suspicion. Otherwise, there's no need of biopsy.
Thank you, sir. Thank you very much.
Thank you. Thank you, Dr. Anant Reddy.
Thank you, sir.
Thank you very much. Second.
Teacher and Guru. Thank you, sir. Thank you very much.
Now the next speaker is Dr. Pugajanthan, and his talk is Medical Device Safety in Leprosy, an Emerging Need for Meteorovigilance. Please have your lecture.
Very good morning to everyone, and I thank our eminent plenary chairpersons for giving me the opportunity. And this is something, the topic is totally like I am taking you into a different version. Okay, from last 2 days you are looking into all the dermatological or leprosy, reactions, and what are the various way of diagnosing everything. But something focused meteorovigilance I am planning to speak because this is a most neglected area which I am seeing. So with this I will just take it forward. Just check it. So the deliberation today is regarding the medical device safety in leprosy. It is an emerging need for meteorovigilance. And just how many of you know about meteorovigilance? Raise your hand. Meteorovigilance. Pharmacovigilance. Pharmacovigilance. Okay, fine. Thank you. So actually I am speaking something which is a government of India scheme actually. And it is mandated by MBBS, MD, DM or irrespective of any super speciality, you are supposed to know. Because we are dealing with each and every medical device in our day-to-day activities. So first I will say what is this meteorovigilance. It is a science and activities related to detection, assessment, understanding, prevention of adverse events or any other medical device related problem once the device is available for public use. Understood? Why I took this topic? Everybody was saying from last 2 days we were saying what are the diagnostic available, what are we are using for reconstructive surgery, what are being used in the leprosy hospital. Each and everything is coming in touch with the patient. Okay, so anything which is coming into touch with the patient is a medical device, and there is always a risk when it is coming in touch with the patient, and we should be very much cautious regarding that. So be cautious, be aware. So what comes under medical device? Just see this as per 2017. Instrument, just checking a sugar value for a leprosy patient. Okay, just checking any PCR machines, anything which is coming in touch with the patient. Instrument, apparatus, like what are the apparatus we can use? We can use processes, we can use many, even simple a cotton, the gauze which we are cleaning the ulcer wound, everything. It is all coming under medical device. So instrument, apparatus, machines which we are using for nerve conduction study, which we are using for giving a physiotherapy for the patient, appliances, implants, reagents, in vitro use, software product. I am taking an X-ray of some bone, but the software is if there is any issue with the software, it is going to give you a wrong value. Okay, so again that is under a medical device, and finally the materials whichever we are going to use superficially for the patient. So they are all coming under medical device. How medical device differs from a drug? Drug, it alters the biochemical as well as the physiological process. With the device, it works through the physical and mechanical means, which is very common in leprosy. In drug, we are seeing into the safety and the efficacy. in medical device we are seeing the safety and performance. That is very important. Performance. I am giving a prosthesis for a patient, but it is not working means it has to be reported in the medical device safety. So for drug we have to undergo all the clinical trials from zero to phase 4. With the respective device, it is a clinical evaluation of the feasibility of the device. And drug, you know, it is very much, there is a huge, years and hours are needed for developing a drug. Here, with respect to device, it is manufactured through various processes ranging from a simple assembly to the sophisticated fabrication. Drug causes local and systemic toxicity, and device, it is biocompatibility. Why I am saying means, if you are not properly assessing the patient fit for using any of the processes, you are going against this. Okay. So again, please, this is very much important. Just at least know the classification of medical device. Okay. Low risk to high risk. Keep it as simple as it possible. Whichever coming superficially, touching us, it is low risk, class A. As we enter deep into it, like superficial, for example, I am using a glove, I am using a dressing. It is class A or low risk. Little bit I am penetrating. I am putting an IV set, vent flow. It is class B or low to moderate. Moderate to high risk is like I am putting an intraocular lens or some bone fixator, or in the case of leprosy, it is processes. They are coming into the class C, and the final is high risk. When I am putting any device deep into the body, like strength, anything, it is coming into the class D. So at least keep in this mind whenever you are touching a patient, which class of medical device you are going to use and what is the anticipated effects or events you may get. Why there is a need of material vigilance? So these are the various examples. Okay. Somebody was kept in the MRI machine. The MRI machine was not functioning. He got sophisticated and died. Okay. During the time of COVID, there are lots of pulse oximeter. Pulse oximeter, default pulse oximeter gave the saturation level very low. Because of that, doctors have started steroids. Because of that, unnecessary exposure to drug. So there is a need. Whatever, for example, because I worked in Central Leprosy Teaching and Research Institute, we have a physiotherapy unit, we have all the surgical unit, we know how many instruments are coming in contact with the patient. Okay, so that is the need I felt that the integration of material vigilance in the focused programs. So it was formally initiated by the government of India on 6th July 2015 at Ghaziabad. And what are the benefits of this material vigilance program of India? Okay, first and foremost is the patient safety. Then comes to quality improvement, regulatory compliance. Because if you are going to find, you are using a monofilament for testing. Okay, if there is, you feel that this is not functioning, try to report to the government. Okay, we have to look for the manufacturer, we have to try to remove it. Risk management and safety of the public health, and finally the economic impact. Why material vigilance is important again? To ensure the safety of more than 1.4 billion Indian people, to generate medical device safety database on Indian population with respect to the general population and with respect to the disease. Okay, even with respect to the leprosy, to provide safe and effective medical treatment is one of the mandate of Indian government to reduce hospitalization and thereby reducing significant economic burden on patient as well as in the country. Updation on patient or user information leaflet, new medical device adverse event monitoring center, warning, contraindication precautionary measures, and to avoid the substandard materials being circulated in the society. So this is what you have routinely we are speaking for the last 2 days. We have to do a nerve conduction study. Whenever there is a partial nerve involvement, we can go for the nerve stimulation. There is a role of infrared therapy as well as physiotherapy. And in the surgical area, claw hand correction, nerve decompression surgery, skin grafting, splint and orthosis. These are the wide area we are using all these medical devices, and it is our duty to ensure that what we are using is right or not. So why in leprosy care? As I already told you that device related risks in leprosy care, extensive use of medical device in patient with a reduced pain sensation due to the nerve involvement increases the risk of unnoticed injuries. This is what the example like burn injuries from improper wax therapy, pressure ulcers from ill-fitting prosthesis. So there is a need of material vigilance framework. Strong material vigilance framework is necessary to monitor and manage medical device related risk and leprosy care settings. So these are the few of the recommendation which was mainly by the end user who are reported to the Government of India stethoscope, like mandibular reconstruction plate, coronary stent system, pacing lead, umbilical cord clamp, infant incubator, HCG pregnancy test kit, and total knee replacement. All these processes was found to be substandard, and it was called back by the Government of India when there was a proper reporting. My intention of coming to this conference is I want to create the awareness from the UG to PG and otherwise the person who is practicing leprosy. So need of material vigilance in leprosy hospital. Incorporating material vigilance in leprosy hospital is not merely an adjuvant component but a necessity for ensuring patient safety. Leprosy patients suffer from chronic ulcers, neuropathy and musculoskeletal deformities, relying heavily on medical devices for mobility, therapy and daily functioning. So material vigilance is essential due to the impaired sensory function in leprosy patient, helping prevent undetected injuries caused by medical device from worsening into the severe complications such as infections and pressure ulcers. So these are the posters released by Government of India. This is with respect to the ortho department. So more or less we can, wherever there is a possibility, we are supposed to intimate to the Government of India. How to intimate? There is a toll-free number, and I will say which toll-free also. So integrating material vigilance in the routine clinical practice ensures early detection of defective device, immediate reporting and prevention of risk, fostering a culture of safety and accountability. So we have to build a culture of safety and accountability. We have to be proactive measures, helps ensure compliance and reduce morbidity from the device related injuries with respect to leprosy. Who can report? You are saying, sir, you are speaking about, because everything we are only using now, we are using at the patient side. So yeah, clinical specialists, biomedical engineers, nurse, pharmacist, patient himself, hospital technology manager, technicians, anyone can report. Who can, what they have to report? Whether it is serious or non-serious. For example, wearing a glove and doing something, after wearing a glove, somebody is getting itching. It is non-serious, but it is better to report. Okay, because it may become a serious for someone else. So whether it is serious or non-serious, known or unknown, frequent or rare, or disregarding of established causal relationship between the event and the medical device, do report. Here the concept is, whichever you feel that is abnormal, report it. How and who? We can approach this at www.ipc.gov.in, or there is a toll-free number 1800-180-3024. Okay, please at least keep this. For drug or device, you call them in your local language, irrespective of there are around 10 languages are there, you can report. Okay. So recently this is my publication, day before yesterday it got published, because I felt that there was a meeting with the Government of India 3 months before. There I stressed the fact of integrating material vigilance in the leprosy. Then immediately I wrote a paper for a perspective and it got published. If you want to go through what is the importance, kindly you can have it. With this, I thank each and everybody, judges for providing the opportunity and the organizer for giving this topic in this Lepcon 2026. Thank you once again.
Thank you, Dr. R. Have you any question? Thank you, have elaborated in a nice way. Now the next speaker.
Thank you.
The next we invite Mr. Madan Raj David to present on 3D printing as an innovative tool for hand and foot deformity management in leprosy rehabilitation. Over to you.
So good morning everyone. Can you hear? Yes, thank you. My name is Madan Raj David. I am representing Leprosy Mission Hospital 9E. My topic is 3D printing as an innovative tool for hand and foot deformity management in leprosy rehabilitation. So this is my introduction. Everyone knows it is involvement of peripheral nerves. It's more commonly in upper limb, 3 nerves are involved, like ulnar nerve, median nerve, and less commonly radial nerve, which leads to deformities and resulting in loss of hand functions. And as a therapist, we usually give hand splints to enhance hand function. So usually we use conventional splints like POP splints, aluminum splints, finger loop splints to correct the deformity. They are very good in achieving the goal of rehabilitation. But you know, in leprosy, it's not only about stigma the person feels, but whatever product the patient use also carry a stigma tag. Usually you feel like whatever splints we give, they won't use in their community setting, feeling like ashamed of using the product because of the appearance of the splint itself. So here comes the importance of compliance. If they are not going to use it, you are not going to get any good result. So here comes the importance of using your technology to address the gaps of the conventional splints. So why 3D printing? So with this 3D printing technology, we are able to make customized hand splints for the patients. And it is cosmetically appealing, so that, and we are promoting that not as a medical product. So we want to promote as a cosmetic product, as a fancy product. So they are not associating that with a medical aspect. So they are encouraged to use in their community setting. And this is not a new technology. Actually, it has got an origin from 1983. But if you see, in leprosy, we have started from 2020 onwards. So roughly this is the process we follow in 3D printing. So it goes through three main processes. One is pre-processing. Here we have to take the physical measurements either using a vernier caliper, or you can take input device like 3D scanners. Usually Creality slicer or iPad structure sensor can be used. Once you capture the image, then we go for designing. So that is nothing but CAD design you have to do and convert into a STL file. Usually we do use Tinkercad software, which is a very simple software. Then it has to be sliced in a language which the 3D printer can understand. That is called G-coding. So that we do with the Creality slicer. So first phase is over, then actual 3D printing. So now once the design G-code is there, we have to insert in the, take and insert in the 3D printer. If you give print command, it is ready to print. So usually 3D printer, it prints in 3 dimensions, that is X, Y, Z axis, and keeps printing in layer by layer. And this technology is called fuse deposit modeling. So then comes the third phase. This is actually the print is made. Then we have to remove the unwanted structures, file it nicely, and you have to evaluate for fit and function. If there is no problem in using the splint, then we give, we inform the patients about do's and don'ts, and we deliver the splint to the patient. So this is the process of 3D printing. And this is about the 3D printer. In our facility, we use 2 types of printer. One is more useful for printing flexible filament, which is called TPU, thermoplastic polyurethane. And another one is more useful for printing ABS filament. So these are some of the products we print in our facilities, mainly for upper limb rehabilitations, which can be used for preoperative patients as well as post-operative patients, depending upon the need of the client. So starting from ring splints, gutter splints, and usually we use these buddy splints in some RCS patients. They have limited grasp after, because of adhesion, they won't be able to get full fist. So this buddy splints help in encouraging range of motion of the digits. So these are some of the splints for ulnar nerve palsy for claw correction. So this is mainly to show how customizedly it can fit with the patient's hand. And the second photo to show in post-op rehabilitation, some patients, they will be unable to do coordination activities. So for that we give this finger sleeve splints. And for AIIMS deformity, we use these short opponent splints to keep the thumb in palmar opposition position. And in post-op complications in mobile hand, hypermobility hand, there is always a chance of developing swan neck fingers. So we use this swan neck splints. And there is an option of using different multiple colors to, depending upon the patient. If females, we use more colors. If male, we are trying to go for transparent filament in use. So these are some of the things we can actually do with a very severe case where splinting is not possible, where still we have to make our patients functional in our ADL task. So for person who doesn't have fingers, we go with a universal spoon, which is like a slip-in through mechanism. It doesn't need anyone's support, so they can insert and remove by themselves. And there is another splint given for a person who doesn't have a amputation, forearm amputation patients, where we have taken the image of the area of contact, so where he can slide in through the customized eating aid. So that has been designed specifically for this patient, so that it will fit only him. And there are different writing aids depending upon the function. And this is one of the interesting things. We all know surgery can correct the deformity mainly for the reduction of stigma. And we got a female patients who came with claw hand as well as index finger digital amputations. So first we have done the reconstructive surgery, then we fitted with finger prosthesis. So not only that, because of that, it improved her appearance as well as she is able to do functional tasks like picking and writing. So for what all splints I presented, this we are doing in our facility. So this is related to foot, and we are not doing in much, but our TLM centers, some of the centers in Tamil Nadu and Delhi, I think they are doing this foot insole technology. This is an interesting thing. For leprosy, we usually give MCR footwear, irrespective of their problem. But each and every one are unique. If you see like everyone dressed in your own choice. So likewise, we have to respect patient's choice. They usually want to have their own footwear, and that we respect. And what we do is, we just make an insole according to their own architecture of the foot, considering the factors like whether foot is pronatory or supinatory, thinking what for future chance of ulceration, we modify that in the insole and give this product which can be used in their, fitted in their own footwear. So that is one interesting thing about this customized insoles. And this AFO, I think, just to show like how creatively if you design, the product will be aesthetically acceptable, spontaneously acceptable for everyone. So which is not tried in our center. So in future we are trying to use it. So these are some of the common advantages of 3D printing. One is rapid prototyping. This is nothing but you can customize according to person's need, and that file is always there. Whenever you want to change or modify in future, that is possible. And anyone who has the interest to learn this printing technology, they can learn. So basically I'm an occupational therapist. We learn this skill by watching YouTube videos. It's not a great deal. If you have interest, you can do it. And the cost of raw material is very cheap. And you can have collections of files. Usually you can download online also. Many groups or community groups are there. They will also support you in progressing forward. The main highlight of this printing is its cosmetic value and appearance, which we want to get from this technology. Because of that, the patient is able to use this, and without fear, they are able to use in the community. So that is the highlight of thinking about this new technology. And some of the disadvantages, like it's not a disadvantage, but it's an initial investment. Printers are quite expensive, and basically you need a constant power supply. The area should be free from dust, and service availability is a key. Like if there is no service available for this material, then it's a challenge for us to move forward. And the way forward is to train and build capacities of therapists and P&Os who are involved in this field, and to conduct multi-centric studies to know its effectiveness. So the point of coming to this conference is like, we want each and every organization who are working with leprosy, think about this and try to implement in your center, which will change the result of this 3D printing in our country. To integrate medical service with IITs for wider impact. Because like we cannot do alone. So we need the capacity building from the IITs who are like more superior to us. So they can help us to create more models easily, and to include 3D printing in national level programs. Based on the success, we recommend it should be, maybe from the feedback, we can incorporate in our national programs. And in conclusion, this technology, if used wisely and creatively, can benefit many clients in preventing deformities, reducing stigma, and enhancing functions. In rehabilitation, innovation is not about machines only. It's about restoring dignity. So this is what we learned from this 3D printing. So in leprosy, in our hospital, like patients, it's free hospital and we won't charge them. And if person, like if he misses the splint, if he asks them to pay the amount, he is still willing to pay for that. So that is a testimony which feedback we received from the patients, which motivated us to work on this 3D printing process in a more elaborative way. Thanks for your patience listening.
Thank you, Mr. Madan Raj David, for your lovely presentation. The floor is now open for questions.
Are there any questions? Yeah, I have two questions from Mr. Madan Raj.
Yes.
One is, you made a statement that reconstructive surgery is mainly for cosmesis. But let me remind you, it's mainly for function,
yes,
to improve the way you grasp a particular object, and also to improve your grip strength. These two other things. The second thing is, it's excellent presentation with a very good these things. I'm glad you made the colors for men and women different. Some of the colors were very, very bright. I was wondering whether I would wear that. But you have an option of colors which is very good. And the other term you used is fit and function. I would like to add a third F to that, the friction. It's a device and you're going to have friction while using that. But you said the material is soft. Some of the 3D printing material I've seen is quite rigid.
Flexible filaments.
Yeah.
TPU is there.
So fit, function, and friction. But an excellent presentation and an innovation which is worth carrying forward. Thank you very much. Thank you.
Thank you, sir.
What were others? No more. I don't think we have any more presentations. Two of them are absent. I have a few comments. First, on the presentation of Dr. Anant Reddy. Thank you, sir, for bringing a very important aspect of reconstructive surgery that we should have a special focus on the children. Sometimes all these children are put together with the adults, and the problems they have are slightly different, as you pointed out, writing, and more of a integration problem in the school, and especially plantar ulcers. When they get it at such a young age, if you don't take care of them, both their soft tissue and skeletal structures are destroyed in no time. By the time they are adults, they are in teenage, it's gone. So we need to have a special focus on this, and maybe the NLEP as well as the ILEP and other organizations which are doing reconstructive surgery should probably have a separate parallel line, even though procedures and other things are same, but to have a special focus and see if there is any special needs for these children. And those results need to be analyzed separately. Usually children do very well with reconstructive surgeries. So that's my other comment. The third comment is on this, what is this? This appliance vigilance. Yes, it's very important because we use a lot of appliances in leprosy, as pointed out, prosthesis. We have used sometimes calipers, you use splints, use footwear, offloading devices, and so we need to be careful. Again, the three F's, which is just fit, function, and friction, these are very important. And especially when they are mass-produced, as the presenter said, sometimes the fit may not be custom-made and individualized. Then it may cause a problem. It may cause a problem, especially if you're using it in anesthetic feet and anesthetic hands. they may produce some ulcers. So that's my comment on that. And previously, in the earlier IIL conferences, we used to have a reconstructive surgery session and then a rehabilitation session separately. But now I feel that all the papers have really reduced as far as these two topics are concerned. We have a grand number of 4 papers, including one paper from the previous session on plantar ulcers. But there is so much to be researched in RCS as well as rehabilitation, prevention of nerve damage, reversal of nerve damage, correction and rehabilitation. And I hope the youngsters will be able to take up these research topics and take it as a challenge. And for the next IIL, we'll have lots more papers under RCS and rehabilitation. I would like to thank my co-chairs, Dr. Mishra and Dr. Helen, and thank you very much. There's a question, yes. Yeah. Yeah, thank you for asking this question, very important question. The youngest I have operated for reconstructive surgery is 7. And yeah, between 7 and 15 we have operated many patients. In fact, you will find out that these children do much better. Their coordination is much better, their learning ability is much better. So I wouldn't restrict the things for 15. And if NLEP has given those guidelines, maybe they should have a small committee to revise and see whether we could lessen the age. We could improve the age from 7 to 15. We could include it at least, say, 8 to 10, 8 to 15 or something like that. The other important thing is, most of the reconstructive surgeries are done under local. So when you're doing with children, you must be careful, because under surgery, they may not be cooperative, under local, especially with the tunicate pain. So that's why we tend to give general anesthesia to these patients. If especially we feel they are of the younger age group and they are not able to cooperate with the surgery. It's an excellent question. That's why I said the children have to be treated as a separate group. And I think the NLEP should take note of that. And maybe we should have 2 streams, adults and children. Even though procedures and other things remain the same, the focus is slightly different. Thank you.
Thank you, sir.
I would like to call Dr. Mani Vannan sir for his talk on 3D printing as an innovative tool for foot deformity in mobile leprosy clinics in Tamil Nadu. Thank you speakers and chairpersons for that insightful session. I request you to kindly receive your memento. We will now take a short tea break. Kindly reassemble in 10 minutes to continue the proceedings. Dr. Neeta Agarwal ma'am, Dr. Santosh Rathod sir to kindly take the seat on the dais. May I request the chairperson, Dr. Veerakumaran sir, Dr. Madhukar sir, Dr. Nikita Sara ma'am, Dr. Neeta Agarwal ma'am, Dr. Santosh Rathore sir to kindly take the seat on the dais. Where are you based? Patna.
Shall we start, ma'am? Good afternoon, everybody. It's nearing the fag end of the conference. And just like that, we as clinicians, we know about the patients only during the treatment period. But what happens to the patient after the treatment? So that is what we are going to discuss about. And just like the fag end of the session, of the conference, we are also going to do what is happening to the patient after the treatment is complete. So the rehabilitation of the patient, that's what we're going to do. The papers are for this only. So let's welcome Dr. Joy Deepa Darlong madam. She had already given an excellent presentation yesterday. So we'll see her presentation now.
I'd just like to add that social aspects sometimes are the most neglected one. And I'm really thankful to Lepcon for adding this great session. So look forward to hearing from Dr. Joydeepa.
Just now it became good afternoon to all of you, and we've come almost to the end of this conference, and the more I think about the tagline, Leprosy-Free India Moving Closer, I feel that we are deep diving into more relevant issues in a much more comprehensive manner. So this topic that we are going to discuss today is developing best practices in leprosy. And in today's talk, we have these slides that I'm going to talk upon. So in this, leprosy programs are today guided by the three ambitions of zeros: transmission, disability, discrimination. But where do we really stand? To develop best practices in leprosy care, we must actually examine our progress across these three pillars. So what is a best practice? I mean, we use this word so rampant, and there are sometimes people who say that we won't use it as a best practice, but as a good practice. What is best practice? So best practice is an approach that is evidence-informed, effective and measurable, feasible in real settings, sustainable and replicable. We cannot take best practices with a fraction of what the statement is. It has to be taken from evidence to replicability. Only then that particular activity becomes a best practice. So we will realize that many of the things that we talk about as best practice are probably halfway through becoming a best practice. It's not what we usually do, but what consistently works. And it is not intention. I want to do this, or my recommendation is this, but it is something which is consistent with a measurable impact. So how are best practices developed? This is the crux of today's talk, and you can see this flow that you have identified a problem and you found some evidence that yes, the problem really exists, and the burden or the prevalence of that burden you found. And looking at that burden, you want to address that burden with some guidelines. You prepare those guidelines, and then you implement those guidelines. After implementing those, you want to evaluate whether the guideline really worked or not. And then you finally refine that guideline and make it into a best practice. So here I would like to give you an example. For example, a problem of reaction management. You know that reactions are the cause of preventable disability. We know that. Then there are several studies which said that yes, X number of percentage develop disability at diagnosis. So many people developed disability due to reactions after patients has completed treatment, after RFT has been done. So we have a lot of evidence. And then there is a guideline which tells us how to manage reactions. Not only the steroid protocol, how to manage the steroid side effects, what the tapering schedule should be, what needs to be monitored, what blood tests need to be done, and so forth. And if steroids are not working, what is the second line of drugs, whether those second line drugs are working or not, whether there is a new need for newer drugs to be tested upon. So all those guidelines are there. Then we have guidelines for vulnerable populations like children and pregnant women and etc. So then we see that the guidelines need to be implemented. That's where the problem starts. The guidelines and the evidence and the problems are generated in halls of offices and hospitals and tertiary care centers and centers of excellence. But when the time for implementation comes, it needs to be implemented where the patients are. And where are the patients? Certainly they are not in large numbers in the tertiary care centers. They are out in the public health system, in the PHCs and the district hospitals. And the question that we need to ask then is my guideline, or is this fancy, I wouldn't say fancy, is this excellent evidence-backed guideline getting implemented in full, getting implemented according to its set guidelines? This is where we need to sit and ask. So we can ask take so many problems, and we have wonderful, excellent guidelines. And how much is it being implemented, whether it is getting measured, whether it has been evaluated, whether it has been feasible, and how much of refinement has happened according to context. The tagline here is, best practice is not declared. We and you and I shouting from the rooftop saying that this is a best practice will not work unless we have tested it and made it institutionalized. So where do we stand in leprosy? How does the previous flow chart stand in leprosy in terms of transmission, disability and discrimination? We are strong in saying that widely MDT is available. Yes, it is available everywhere. Active case detection campaigns, yes, they are happening. Contact tracing is increasingly detecting newer and newer cases. SDR PEP is being introduced in many, many settings. We have integrated primary care with leprosy and it's happening. But then what are the gaps that are remaining? Child cases continue, delayed diagnosis persists, neuritic cases are getting missed, contact screening is inconsistent in quality, post-exposure prophylaxis has not been universally scaled. So in transmission, high quality contact tracing needs to be done, early nerve function assessment at diagnosis, uniform screening standards and monitoring of child proportion needs to be done. So at this time, the statement that we need to see is, as long as children continue to present with leprosy, transmission is not interrupted. Where do we stand in disability? We have very clear MDT protocols. We have reaction management guidelines, reconstructive guidelines, self-care models, CBR initiatives. But we know that there is still a lot of grade to disability coming at diagnosis. Reactions are being diagnosed late. The last 2 days have been all about this. Nerve functional monitoring is very, very inconsistent. Nobody is reporting sensory loss, grade 1 disability. Post-MDT follow-up is practically not there, and functional outcomes are not measured. We don't even see what is the functional outcome. Mandatory nerve function charting needs to be done. Early reaction recognition protocols need to be done. Yesterday we heard that 37% of patients with MB cohort had reactions at diagnosis, and that too, most of them were severe. Why do people have to roam around with a severe reaction, hopping from one healthcare provider to another, and finally get diagnosed when they have a lot of irreversible issues? Why do they have to incur financial losses of just hiring a car or a vehicle, hopping from one city to another, one place to another, seeking guidance? We don't have longitudinal follow-up beyond MDTs, and we don't measure outcomes. We just love to do prevalence studies and say this is our burden. But like our seniors who guide us and mentor us always tell, let your research be just not bringing out the problem, but come with the solutions as well. Come and implement it, make it feasible, and then it becomes a best practice. So in disability, reactions are the tipping point between cure and disability. In discrimination, again, there are a lot of things we are strong in. We have come a long way, I agree, but there are still gaps that remain. Internalized stigma, participation restriction, mental health, social rehabilitation, uneven scaling, and discrimination indicators are not measured. So best practices required a lot more activity in looking at zero discrimination. Clinical cure does not automatically restore dignity. This was the talk that I gave yesterday, that just getting bacteriological cure is not enough. We need a holistic care, holistic healing. And when we are able to restore dignity despite people living with disability, that's where healing and recovery starts happening. Gaps that still undermine, we have a fragmented continuum of care. Episodic. When a patient has reaction post-MDT, he will come. We treat, he goes back. But there is no monitoring. If he has a new patch, we say query relapse, we test for resistance, then we diagnose it as resistance sensitive to MDT or resistant to MDT and treat. But that's not how it should be. Treatment cannot be in silos. So our care models are short-term, but our disease trajectory is long-term. There is a disconnect. Then there is a weak longitudinal monitoring. What we do not measure, we cannot prevent. Let's start monitoring longitudinal trajectories of the disease. There's variability in peripheral capacity level from state to state, from block to block, from district to district. Everywhere capacity changes every now and then. Tertiary care best practices mean nothing if it does not reach the periphery. Let's admit that, and let's include and inclusively take peripheral health capacity into our wing. Under integration of holistic care, like I said, leprosy affects nerves, but it also affects identity. Can we move beyond nerves and patches and look at the person as a whole and look at the identity of the person to restoration? Limited implementation science. We pilot well, but we scale it inconsistently. So these are some of our gaps in 3 pillars. What is needed now? Just not guidelines. We have sufficient and best quality guidelines. We need to implement them, and we need it consistently. Longitudinal care models beyond MDT completion is very, very essential. Outcome indicators that matter will measure disability progression, reaction detection timings, functional outcomes, and participation outcomes. And we need to scale what works and find out what fails. Key takeaways. Best practice is a measurable impact, not routine practice. Progress in leprosy must be assessed across the 3 zeros. Disability and stigma persist largely due to implementation gaps, not because of lack of guidelines. Can we take a decision to move away from guidelines, use the guidelines that we have, and then go on to plug those gaps? Strong peripheral capacity and longitudinal care will be essential to achieve the 3 zeros. The next phase of leprosy control must focus on standardization, monitoring, and scale up. So best practices at the center, early detection, sustained timely reaction management, and sustained support for zero discrimination is the need of the hour. A patient cured of infection but left with preventable disability is not a success for us. A patient treated but socially excluded is not fully healed. Best practice is our bridge from treatment to recovery. If we are serious about our business, then best practices cannot be theoretical. It has to be implemented, standardized, monitored, and taken at every level of care. These are my references, and thank you for your listening.
So we'll have questions at the end of the session. Thank you.
Can we call the next speaker, please? Joshua, sir, my teacher.
Good afternoon, everyone, respected chairpersons and my dear friends. We are addressing gaps and unmet needs in leprosy rehabilitation. I've got a list of 5 gaps that I found. We always look at grade 2 deformity among new cases, but we never look at grade 1 deformity among new cases. And grade 1 disability today becomes grade 2 deformity tomorrow. You know, WHO has convened, for those of you who are not familiar with this grading, grade 1 is, I'm talking only about the limbs here, is anesthesia or loss of sensation, and grade 2 is visible deformity. It could be because of motor paralysis, it could be because of loss of sensation. Now, loss of sensation leads to a certain way of using the limbs, which can create some amount of deformity and disability, and that happens the next year. Whereas this year, the person was in grade 1 deformity, and the people, and Joydeepa has said, if you don't measure, if you're not asked to measure it, we don't implement it, if we don't see it. So if we are only looking at grade 2 disability, we leave all the grade 1 disability. And grade 1 disability becomes grade 2 disability the next year. And we are not looking at those people next year. We are looking at a new set of people who have grade 2 disability among new cases. So that brings me to the second gap. Okay, why I went through this, why is it important to look at grade 1 disability? Loss of sensation today results in ulceration or disintegration tomorrow. I'd like to qualify that for about disintegration. Now, gap 2, we look at grade 2 disability among new cases. The old cases are ones that are progressively going into disability. A grade 2 disability among the new cases this year is not recognized the next year because it's not among new cases. So they slowly start their journey to amputations. We had that excellent presentation on children today, and when children have anesthesia, they don't just walk their way to amputation, they just hop, skip, jump and run their way to amputations. And so we have to look at this, as Joydeepa kept saying, longitudinally, continuously following up these cases. Why is it important to look at grade 2? If we do not look at these patients, we will miss some of them who develop new nerve damage during or after treatment with MDT. We will miss those who continue to damage themselves because of the sequelae of leprosy, even if they were recognized to have grade 1 or grade 2 disability as a new case. And then the next year we look at the newer cases. We don't follow up the older cases. And we are not asked to follow up. And there are no indicators that we have set, because only if we have to report on something will we do something about it. We miss continuing care for those who are diagnosed and recognized as grade 2 disability when they were new cases. Another thing that we do is, the third gap is, we continuously talk about ulcers. We talk about insensitive limbs that slowly disintegrate with ulcers. The concentration is on the ulcer, is on the wound and not on the limb. But many limbs just disintegrate without ulceration. Health workers concentrating on ulcers, forgetting that limbs, especially feet, even hands, but especially feet, keep disintegrating slowly, even without ulceration and even without paralysis. The concept of the hot foot or the hot limb and how it needs to be protected needs to be on our minds, but it is not there. It is not there in the forefront of our programs. It's ulcers, care of ulcers, that takes over, and everybody goes on into caring for ulcers, imagining that such a foot is normal. Whereas you can see from the X-ray that the talus is fractured. You can see the, I'm sorry, I'm not able to operate. Yeah, I am, but I'm not able to point. something's happened.
You can operate on the computer, in the computer itself.
Okay. Please believe me, the talus is fractured, the head of the talus is in pieces, and that's one of the early things that happens in in disintegration of the midfoot. Oh, this is okay. Yeah, thank you. So this is the talus, this is the navicular, these are the cuneiform bones, and here is the head of the talus, which should be here, which should be articulating here with the navicular, and it's missing. Forget it. Yeah. So that is one of the things that we should remember. Many feet, many hands disintegrate. You know, many of us turn keys in a lock, and when we are not able to turn it well, it's an activity of daily living, and when we're not able to turn it, we force it. Now, people with loss of sensation will use even more force to the extent that they may dislocate their metacarpophalangeal joint or their interphalangeal joint, or cause wounds in their hands. Now, I'm not talking about wounds, because wounds are immediately recognized, and care for wounds is not an unmet need. But care for this kind of disintegration is what is lacking, because such a foot needs to be immobilized, treated as a fracture, treated as a ligamental tear, and it has to be immobilized for a long period of time, and after that will require customized protective footwear which will see it through till it is strong enough. Okay, so here's one. This is not really a hot foot, it's also got an ulcer. You can see I've shown the left and the right foot of the same person, and again you can see that the ulcer is not in the usual position. It's in the midfoot. Usually we get ulcers in the forefoot or in the heel, but here you have it because there is a collapse, and I'll show you the reason for the collapse. Yes, here, notice the difference between the two x-rays. The one on the right there, of the right foot, shows you the normal architecture, though it's not positioned correctly. It shows you the normal architecture and the normal arch. Whereas on the left foot, you can see the collapse and you can see the fracture of the talus and the disruption in the navicular here. Whereas there you can see, on the other side, you can see the bones individually and looking normal. So this is something that we miss out constantly, and it's happening to many, many feet. The number of deformed feet that we see is because of this kind of disintegration. We pay attention to ulceration and not to disintegration. Most of the limbs that we amputate are those that have lost sensation in the joints, ligaments, etc. Charcot's foot, we call them Charcot's foot. In the acute stage, we call them hot foot. In the chronic stage, we just refer to them as neuropathic feet or Charcot's foot. Ulceration in atypical sites follows, and then there is an inexorable journey towards amputation. This is the road to amputation. The pathway to amputation of the leg is littered with bandages and dressings, which have deceived both the doctor and the patient into thinking that by dressing the ulcer, they are curing it. Ulcers heal spontaneously. All wounds heal spontaneously. You don't need an interference. You don't need any kind of medication. If the person is healthy, the wound heals. All that is required is offloading so that that part of the foot is given rest. But I'm talking about feet that are not ulcerated, and here also we see this. Yeah. And these two pictures, the one before and the one here, are what are from Paul Brand's book called Insensitive Feet. You know, people with insensitive feet should always take short steps. I'm hastening to say that it's Brand because I don't want anybody to say that I've asked for feet to be tied up like this. You know, you really don't have to. You've just got to get people walking with short steps. So please don't tie up feet. Allow people to walk, but remember to tell them to walk with short steps. Okay. In case of misunderstanding, I don't want to be misquoted, you can catch Paul Brand. Yeah. Now, 4, aids in appliances, orthosis in footwear. We have the concept of MCR footwear. Almost everybody says, we gave them MCR footwear. The patient, in spite of giving the patient MCR footwear, he did not take care of himself. We get into the victim blaming game. The victim is to blame for the problem, not anybody else. Not the person with the knowledge, but it's the victim. The victim didn't look after himself. We educated the victim, but the victim didn't look after himself. He walked his way to amputation. We have this concept of MCR footwear. I think we should move on to remember that it's not MCR footwear, but it's customized protective footwear. Because this is not customized to the patient can get a shoe bite or it's an ill-fitting footwear, which can cause problems. And there is the need for customization. These 2 feet do not require the same kind of footwear, nor do these 2 feet, nor do these 2 feet. They all require a different design in footwear. So, this is my point, and yeah. Now, I was talking about grade 1, grade 2 disability among new cases. Who will address their needs? Actually, their needs are being addressed partly only if they need tendon transfer surgery. No one is accountable for if their other needs are not addressed, and this is not an indicator we are asking for. And if a person has ulceration of the foot or disintegration of the feet or disintegration of the hand, it is his problem. We say he did not look after himself. We say grandly, he did not practice self-care. So grade 1 disability among new cases, grade 2 disability among new cases. Yes, we have to see grade 2 among new cases. We have to see grade 2 among those old cases as well, grade 1 and grade 2 among old cases. Because those who are under treatment can go in for neuritis and have grade 1. Then we have to prevent worsening of deformity and customized protective assistive devices or customized protective footwear, and not just MCR footwear. It has to be customized for each person so that they do not develop problems. So these are the unmet needs. The need to set up a mechanism to quantify the number of grade 1 deformities among new cases, the need to set up a mechanism to follow up people after MDT, to know the number who develop grade 1 and grade 2 deformities, a need to make health workers realize that limbs disintegrate because of lack of pain even without ulcers. Limbs need not disintegrate, they can be salvaged, they need to be referred. The need for customized protective devices, customized assistive devices, customized protective footwear, not just MCR footwear. Thank you.
Thank you, Dr. Jerry. Dr. Jerry, can I request you to be seated here? Dr. Joydeepa, can I request you to please join us on this stage? We'll have an open forum for 15 minutes, and we request your question and answers right now. So thank you so much, Joydeepa and Dr. Jerry, for the wonderful presentation. Unfortunately, we were going to have a person affected by leprosy from APAR, but they haven't joined, which is really sad because this session on social aspects and a person with lived experience would have been really meaningful, and we would have got to learn a lot. But unfortunately, the person is not there. So now I open this for any questions.
Any questions? I would like to comment, sir. The thing is, there is a thing called early deformity and the late deformity. Now that it has gone to the realm of the leprosy, has gone mainly to the dermatologists, and many dermatologists do not know this concept of early deformity and the late deformity. And early deformity is a place where we can completely treat the patient with just steroids and nerve stimulation and exercises. So this has to be, I think this concept has to go into the budding dermatologist. I think that will be very important. Another thing is the neuropathic ankle. And like you rightly pointed out, sir, that neuropathic ankle is nobody talks about, everybody in this hall was talking about ulcer. But there was no paper even on his neuropathic ulcer. And this is a very important part. So that is easily treated with the total contact casting. So that also has to be, this message also has to be given to the budding dermatologist. And your paper, your this thing, and your concept was the beyond, we look beyond nerves and patches, and what we need is monitored implementation. We fully agree with that, madam. Thank you.
Mike.
You don't have a mic.
You can have this mic.
For them also, you need a mic.
Hello, am I audible? Yeah. So actually we had planned this session like open forum. So throughout the 2 days, if you have any queries or pertaining to this session also, if you have any specific queries, you can discuss in this forum for 15 minutes. Hello. We request Dr. Joydeepa to coordinate the question answers.
Sir, if there is a chronic ulcer, long-term chronic ulcer, with on X-ray there is a pathological fracture of the bones with small pieces around. Is it necessary to take out the bones for the wound healing?
I'll ask Dr. Jerry
Or
to answer that.
by splinting and ulcer care, the wound, the fracture parts will be automatically again reunion will happen.
We have to say, I would say that whether it is a sequestrum or not. If it is sequestrated, if it is sequestratic mean, then we have to remove it. If it is not, if it can be replaced, it can be fixed, then I think it will be better to go with a fixation. If it is multiple chronic ulcer due to this multiple ulcers or there, it's probably a case of neuropathic ankle. And a neuropathic ankle has to be fixed either. First, the thing is we have to think of doing the sequestrum. We have to identify whether it is sequestrum or not. If it is sequestrum, remove it. Do a complete debridement, and then you have to fix it. That's what. That is the concept
Can we go for primary closure of the wound, or we should left the wound open for?
If it is a sequestrum, I think we'll leave it open for some time till it's completely culture free, and then we can close it.
Thank you.
Dr. Jerry and Joydeepa, would you like to add something?
Yeah. See, if, as Dr. Veerakumaran said, if it's a sequestrum, if there is infection, it needs to be drained, the dead tissue has to be removed. Usually, these wounds are not closed if you have both together. Okay? You wait for the wound to heal. But if it is without a wound, if it is a disintegration of the limb, it has to be, and if it's in the acute stage, it has to be immobilized. It has to be immobilized for a long period of time, and after that, it has to be supported with either a fixed ankle brace or a patellar tendon bearing brace, and after that, the person can, after that, probably after 1.5 years or even 2, the person may be allowed to have conventional footwear. Okay, so it's basically a question of resting it, immobilizing it. In the chronic stage, if you find that there is a deformity or the limb is flail and unstable, then you have to fix the ankle. In the acute stage, if you tried fixing, everything will disintegrate during the procedure.
So there are a lot of terminologies which might seem to be very clinical words. There are a lot of people here I've met today and yesterday who are from the periphery, the field level. They probably do not even know how offloading can happen in a PHC. So offloading actually means you don't allow the people to walk. So it can be done in several ways. The best method is to put them on the bed, ask them to elevate their feet with a couple of pillows. That is so easy to do. And then if there is a possibility of a splint, you give a splint to keep the ankle in position. So these are very simple methods that you can use in the field. And debridement can be done and leave it open for the ulcer to heal. So these are very easy to do and can be adopted in the community. Yes, Dr. Bhushan?
I refer to the comments from the chair and a reference to what you have said.
you are in a center which is primary, secondary and tertiary both, all. Because, but otherwise in the periphery where this care is needed the most, there is nobody to guide them, nobody to teach them. And the other important part is, if you tell somebody to take rest, the person has to earn his livelihood and go. So that is the state, and there is no person available for that matter, no orthopedic surgeon, no physiotherapist, or nobody who can guide them. So it is the primary. Tertiary care people are, I don't consider them to be doing something. They are managing, yes, sure, they are doing a lot. That is a different thing altogether. But why should we reach that stage? So primary and secondary is the one which needs to be strengthened, and we have to have kind of people who can educate them how to protect their limb without stopping from going to work.
Yes, sir. We totally agree. The thing is, we are talking about an unmet need. The need is there, the service is not there, it's available only in the tertiary center. It has to be brought to the primary or secondary health center where at least immobilization is prescribed. Immobilization is prescribed and provided. Now, there is the necessity for the concept that rest heals the limb, not dressings or medication. Because many people think that in the tertiary, in the primary or the secondary level, we can only provide medication and dressings. And so that's provided. But that still does not meet the need. The need is immobilization. Immobilization, we can immobilize the patient and still permit the person to walk. So that's healing while walking. That also because the person has, that's what the person's legs are for, to take the person places. So we have to immobilize. So that concept should be brought into the primary and secondary level. If we do not do this, then we are fighting a losing battle. They will walk their way to amputations.
At this point, I want to ask or throw an idea that could be discussed. Leprosy and its management is becoming more and more multidisciplinary. Last year, 2 years back, we had a symposium and Dr. Sunil Dogra had presented an excellent talk on multidisciplinary management of leprosy. Currently, dermatologists and surgeons, plastic surgeons, they are managing. Orthopedic surgeons are coming and doing reconstructive surgery. But we have specialties like PMR, physical and medical rehabilitation. We have neurologists. You cannot imagine the number of phone calls I get from neurologists asking me, patient has completed MDT, he's 6 months back, he has come back with foot drop. Should I start MDT again? So, all the nerve-related problems are going to the neurologist. Where are the neurologists in these discussions? Where are the PMR people in these discussions? Now, with any kind of disability, referral happens to the PMR department, not to the dermatology department. And if they are not a part of this conversation, how can we make it a disciplinary solution, multidisciplinary solution? So let us think through what IAL wants to do, whom they want to include in reaching out to the masses. Today, a physiotherapist might go and finish and open up a clinic in his hometown, and he might get several leprosy patients. If he has been a part of a forum like this, his mind is open to how resting, immobilization, neuropathic foot or a hot foot, that will be open. He would probably look into literature and try and understand. So are we ready to include multidisciplinary teams within us? That's a question I want to ask. Yes, Dr. Paul.
Thanks very much. This has been very impressive presentations. And I wanted to ask whether you know of places where there is the sort of program management and infrastructure that can actually put all this together, because it seems there are not many places that it would happen, and then probably nowhere is perfect. But I think it would be very interesting to have a case report from somewhere that is managing to do this integration and actually maybe within the leprosy mission somewhere in the world, there it may not happen in a very densely populated area, but there may be places where you get this good feedback and integration with data collection so that you know actually what's happening to patients over the long term. But I don't think I know of places where they have that well-run program covering a lot of people. But I wonder if you do have some knowledge of that.
Is anybody there with an answer for this question? Whether there is an integrated model that is looking at a management of ulcers. To some extent, Leprosy Mission Hospitals, Karigiri, we do have protocols, isn't it, sir?
Yeah, we do have protocols, but see, immediately it is seen as being a specialized or a tertiary center. It's not being seen as as providing primary or secondary care. We do provide that. Our only intention is to see that these services which are needed, these are the unmet needs, these are the gaps, they have to be filled at the primary and secondary level. And sorry, Paul, I'm not able to offhand tell you where these things are well available, except that I can say that our center and many of the leprosy mission centers, and I dare say even Chingalpet, Sivananda in Hyderabad, these centers are capable of providing these services, but we have to disseminate them and make known that these are the gaps, these are the unmet needs, and they can be filled, and filled at the field level itself.
Thank you for this. Do we have some more time? Yes, Dr. Mannam.
Yeah, thank you for two excellent presentations, both by Joydeepa and Dr. Jerry. In the first presentation, we are talking about a longitudinal follow-up beyond the MDT. And there are many areas you pointed out, Dr. Jerry pointed out. Do they develop grade 1 and grade 2 deformity at the end of MDT? And sometimes we can even say the contacts are given SDR, and are they being followed up to see whether they are developing leprosy, or do we wait for them to develop leprosy and come and report to us, or is anybody actually going and checking on them? Now, putting these things together with what we are talking about is, see, there needs empowerment at the primary level. There needs empowerment at a secondary level. There needs an empowerment at a tertiary level. It's like a flow.
Yes.
So if somebody, like Dr. Jerry mentioned, you have to educate the healthcare worker to be able to detect what needs to be identified as critical and referred. For example, he said a hot swollen foot, or a person who's having a high-grade fever and chills with a plantar ulcer, a complicated plantar. So is the health worker able to identify those critical issues for referral? Because obviously you cannot enable these things at the primary level.
Yes.
They have to be enabled only at either a secondary level or a tertiary level. And already we are talking about institutions, private institutions which are able to deal with these situations. But can more government institutions be enabled to do that? That's where the PMR comes in. That's where other orthopedic surgeons come in. That's where other ophthalmologists come in. So we need to have, we've talked about see, when we had the prevention and management of disability, it was very clear. We had 3 booklets called a primary, secondary, and a tertiary. Basically, we are talking about that. And if you can enable that, then the longitudinal follow-up will be enabled either for best practice methods to be looked at the grassroots level, or for identification of critical events which need referral. So you cannot have this. You cannot have these facilities available at all 3 levels. We should identify that this flow should be there, and this has been identified long back in NLEP. It's just that it's staying at the primary level. Even at the primary level, it has not been enabled well enough because the healthcare worker is not educated well enough to identify the critical events. It's left with ASHA, there's an ASHA surveillance, but how much can an ASHA do? She has so much to do. Next thing is you have to enable your district hospitals, both for RCS and for management of critical events like hot foot and complicated. Then you enable your tertiary things. That's the only way we can move forward. Thank you.
Thank you, sir. I just want to talk about another gap which has been very, very missed out in all our talks, and it's you could call it, because we call it a rehab gap, because all we are interested is improving disease outcomes in people, right? We want to improve the outcomes of the disease, and we are missing out on a big area, which is the mental health disability. We take for granted people with depression, anxiety, doubts, fears, angers, frustrations, lack of confidence, no self-esteem, and we see this over and over and over again in our OPDs. So for so many of these negative emotions do not even have a diagnosis. If a person comes with low self-esteem, no confidence, doesn't want to go to college, doesn't want to apply to a job because he looks like this, then it is not even a diagnosis. Who will look after him? Will the dermatologist look at him? Will the dermatologist refer to a psychiatrist? Will the psychiatrist say, oh, you don't have an ICD classification diagnosis, I can't treat you? So who looks after who gives confidence? No, there is a hope. You will get better. No, this color of clofazimine will go away. You are, because of what your skills are, you don't need to be inferior to others just because you have leprosy. Who's going to tell these things to the people? Today you have to take rest for 6 months. When we break that news, that 3 months we will give you bed rest. After that we'll see X-ray. If it is healed, then maybe you can take baby steps again. But otherwise, another 3 months, 6 months of bed rest, who's going to understand that concept? Neither the parents, nor the child, nor the adolescent, or if it is an earning member, what's going to happen to the family? We are looking at a much, much larger gap here. And again and again I say, if we are not holistically looking at a person with his livelihood, with his social support system, with his emotional needs, we are losing our battle here. This is a big gap, and let's stop. Bring in the psychologists, bring the counselors in. Let us be an inclusive, multidisciplinary team so that we are looking from all angles. We are not talking about ophthalmologists and all now. So yes, sir. Any comments, any other opinions, any other questions that we want to raise here? Yes, Dr. Pai.
I think a couple of years back, NLEP organized this national level workshop on mentally challenged issues.
Yes.
And instead of bringing psychologists and then counselors, what we need is to establish linkages with the national health, mental health program.
Yes.
There are already national mental health program. I think Jharkhand Ranchi, one of the directors was also there. And in that there has been a structure. But what we need is to implement this. We need to start referrals, cross referrals. And then only we can do justice to the patients.
Yes, sir.
Dr. Ebenezer mentioned also about the guidelines, DPMR guidelines. These are all there, primary level, secondary level, tertiary level. But this has to be implemented in action.
Yes. So
another important thing is ocular leprosy.
Yes.
It is the most neglected aspect in the comprehensive leprosy management.
So that mental health Ranchi meeting had a development of guidelines meeting back after that in Pune, and then the guidelines are no more visible to us anymore. So I agree there are guidelines, but who is going to recognize and refer? Unless I recognize, unless I spend a couple of minutes to know that patient is anxious or he's having suicidal ideations, unless I recognize that, I will refer. I know there is a protocol, there is a referral pathway, but recognition has to be there. And I need to be aware that I need to look for it also, unless I'm aware of that fact. So that is what we need to disseminate among people. Any other thoughts, any other questions? Do the dermatologists have a referral pathway where they see certain issues they cannot manage and then they would refer? Like a hot foot, like a Charcot's foot. Is it visible or is it known to people? And are they able to refer to the right places? These are certain questions we need to ask. Specialists also need to specialize in reference. Yeah. Any last words, Dr. Cherry?
Not really. It's just that we need to disseminate this information to the field, to the primary level and to the secondary level, so that people are able to recognize and refer. It's not just that we have to, and the other thing is that we should try to see that grade 1 deformity and grade 2 deformity are not just looked at among the new cases. We need to follow up the cases longitudinally, because what is a new case this year becomes an old case the next year in the future. And after that, we cease to follow because we are not accountable. We need to we need to ask for these measurements. That's it. Thank you.
Dr. Santosh, do you have a question?
No, that is probably what the thing that you asked. That is why we had this Lepcon in Patna. Because what circles we are all in, probably we know each other and we know where to refer, we know institutions where we should refer. And the sessions from the morning, I think the local delegates from Patna, from Bihar, they have benefited immensely. Like if they are suspecting resistance, where to send. So those things are clear now. If there are rehabilitation surgery, so they have been listening to Dr. Jerry since day one, and those things are also very much clear now. About availability of PMR department, availability of orthosis, so those things are sensitized. And that was the reason we held Lepcon in Bihar, so that nearby highly endemic states, they get to know what is happening at the national field, at the research field, and what all these premier institutions are doing. So hopefully that message is conveyed to the state and to the people of the state, and that way probably the areas which are very difficult to reach, they will get benefited.
Thank you, Dr. Santosh. And with that, I would also like to mention that we should not be forgetting persons with lived experiences, and they also would definitely want to contribute to the research and the program agenda of the country, the state, the bloc, and wherever they are placed. So in that endeavor, we have 4 persons affected by leprosy attending this conference, have a poster in their name, and they have presented it in Hindi to us, and that's a baby step again, and we would also want to take that idea forward later on. Thank you, Dr. Santosh, for your input. Yes.
I'm Dr. Vikas Shankar, and I just thank Dr. Santosh and IAL on behalf of Bihar team. That is a very synthesizing conference for us also, and what the principle behind doing in the eastern part of this people from Odisha, West Bengal, Bihar, and this part of globe, we have really have enriched in this thing. Even in Patna, I was not knowing that our AIIMS Patna, this PMR department is well developed, and there are a lot of facilities given here. So this is the way, this two-way, and I really thank IAL for having this. This is for our synthesization towards this more. In past 10 days, I asked my hospital sister in charge, my department, you give me census how many cases in the OPD and how many cases total in last 10 days in the OPD. It is around approx 4% of leprosy patient we are tackling. Every day new and variety of cases. But this is an enrichment program for us. I thank on behalf of Bihar and eastern part to the IL. Thank you so much.
Thank you. And shall we close the session now?
Thank you. So there have been some really, really overwhelming gaps. It's been decades now we've been talking about gaps. Very less is being done to address these gaps. And like the other day we were talking to some of the students, the PG students in AIIMS in Patna. They're very, very well aware, and they deal with almost 500 cases a year of people affected by leprosy. But social aspects are something that they had no idea. So something that Joydeepa talked about and spoke about, the mental well-being. There was a program on mental well-being where the CLD was taking it up very strongly. Guidelines were made, but then the mental health department said that they will integrate it, and again it's fallen off the radar. I think as all stakeholders, it's important and all the touch points should be aware of what are the gaps and what can we collaborate, because the only answer is that we need to collaborate and work together to ensure that we move closer to a leprosy-free India, and that's the title. Moving closer and reviewing progress. So this has been a very interesting session. Thank you so much, Dr. Jerry and Dr. Joydeepa. Over to you, sir.
Thank you for the very insightful presentations. But the thing is, I found out this, we are seeing only one part of the story. That is, we are seeing from the doctor side, from the medical officer side. But what the patient wants, that is what, because when we get an opinion or the voice of the patient is not heard, that is what is needed, the need of the hour. So whatever we present papers, whatever it is, but we had to get the opinion. And it was very unlucky that, unfortunate, that the patient who was supposed to come, PAL, was supposed to come, didn't come. And it would have been better if he had come and we had got his opinions, that side of the story. That is what really matters. A program will be a success only if the end user voice is heard. So I think that is the need of the hour. Thank you.
Thank you.
Thank you so much.
Respected dignitaries, esteemed faculty delegates and dear colleagues, as Lepcon 2026 draws to a close, we gather here today to celebrate the knowledge shared, the collaboration built, and the inspiration ignited towards these enriching days. To close this ceremony, I'd like to invite on the stage Dr. P.N. Rao sir, past President IAL and President International Leprosy Academy, Dr. Sujay Sunita sir, immediate past President IAL, Dr. Santosh Rathore sir, Vice President IAL, Dr. Devendra Chauhan sir, Vice President IAL, and Dr. K. Rajalakshmi ma'am, CC member and past IAL treasurer. Please join us on the stage. I would also like to invite Dr. Abhishek Kumar Jha sir, Organizing Secretary Lepcon 2026, Dr. Organizing Chairperson Lepcon 2026, Dr. Vikas Shankar sir, Organizing Secretary Lepcon 2026, and Dr. Shwetalina Pradhan ma'am, Scientific Chair Lepcon 2026 and CC member IAL.
मैं कहाँ बैठूं?
Now I would like to request Dr. Santosh Rathore sir, Vice President IAL, to say a few words.
स्टेज का लाइट थोड़ा बढ़ा सकते हैं?
Hello. Yeah. So thank you so much.
अच्छा वो कल स्पार्क होता है, ठीक.
So first, on behalf of the newly elected EC and Dr. Sujay sir and Dr. Rao sir and all of us at IAL, we thank you immensely, Dr. Abhishek bhai, Dr. Vikas bhai, Dr. Setalina, Dr. Shripanna, and all of the Bihar team, all the Department of Dermatology, AIIMS faculties, the students, PMCH faculties, the students, and all those who have been running for the cause of Lepcon 2026. We are heartily thankful to all of you. So actually, since the Lepcon was awarded to Dr. Abhishek bhai and team about 3 to 4 months back, and last 3 to 4 months they have been frantic. We have been communicating with each other on daily basis about 4-5 times, and now almost we are in the speed dial of each other. We have kind of become favorites in our call list for past 3 to 4 months. So on behalf of IAL, I would like, and our president and all of us, I would like to say sorry to if we have not met any of your expectations for this Lepcon 2026. The team here, we tried our best, but as always, conference cannot be a perfect conference and there are many variables. So if there are shortcomings, we take complete responsibility of it, and we are extremely sorry if you have felt anything like that during the conference. Secondly, to all the senior members, past presidents of IAL, all the CC members who still have this fervor, this motivation to come to the cause of leprosy. That motivation, that drive has stimulated so many young dermatologists to take up the cause of leprosy. Maybe they see that there is a quiz, a national level quiz, and that is their motivation to attend the conference. But when they come to attend the quiz, they have to compulsorily register. So they register and they also have to attend other sessions. And that is how, agar nahi chah rahe hain, fir bhi they pick up something. And sometimes they may pick up by surprise. Oh, even in the field of leprosy, so many things are happening. And these are the things that we get to see at the Lepcon. I will not take further time. I will again thank my EC, my president, my past president, and all the team. I will thank the team Bihar. And we tried to provide all the coordination, all the support that we could from the central IL. And according to us, you have done exceedingly well. And you have accommodated most of our requests. Most of the protocols of IAL, they have also accommodated. So we are thankful for each and every help and each and every task that you have done for Lepcon and for the cause of leprosy. Thank you so much. I would request you.
I also echo all that Dr. Santosh mentioned. We are deeply grateful to the local organizing team for the arrangements made, and I think they've done the best they could, and we really appreciate all their efforts. I'm also happy that so many of you participated in the conference, presented papers. It is very heartening to see young postgraduates send in abstracts and present these papers, and they're such good quality. We want to appreciate you, and we believe this is a season where there's a growing interest in leprosy among especially young postgraduate students. You are choosing topics for your dissertation on leprosy. You are wanting to do special projects on leprosy, and we want to encourage you to keep it on, keep going, and there is much to be looked at in leprosy, much research to be done, both clinical and laboratory, programmatic, social aspects, and I think it's good if you can take these topics up. We want to thank all those invited speakers. Whenever I picked up a phone and invited you to come, you accepted the invite, and many of you gave very significant lead talks and follow-up talks in the sessions, and I want to thank all of you. Thank you for also Dr. Paul Saunderson for accepting our invitation and coming all the way, braving the Indian visa system and coming and delivering a talk here. Thank you, Dr. Paul. Also to Sandeep, Dr. Sandeep from Cambridge. We are very honored to have you, Sandeep, and also your interactions in different sessions. Thank you for accepting our invitation to travel from UK and come, and it gives you an opportunity to see your parents also in Andhra Pradesh. So thank you for coming. I think it was very significant also that the government of India was represented. We were hoping that the Deputy Director General, Dr. Sunil Gitte, would be able to come, but he apologized because his wife was not well and he had some personal matters to take care of, And so we are very happy that Dr. Lily Gangmai, the Assistant Director, was here. And I think some of the interactions with her also in the sessions was significant, that the Government of India is looking to work closely with IAL as its partner, looking for dermatologists in the IADVL as potential partners, and so I think that is a very positive movement forward, because we believe that in the days to come, yes, nephrologists, more of us need to come forward in the field of leprosy and do more, but also we believe that dermatologists who are trained in leprosy should also be inspired to be frontline workers in the diagnosis and management and prevention of disability. I think you have that ability to really prevent disability, proper management of reactions and neuritis, nerve function impairment. I think all of you know the theory of it, and you can do it very, very well as you handle. So I want to inspire all of you dermatologists to really take up leprosy as to keep leprosy on your agenda, you know, besides cosmetic and cosmetology, but that leprosy will figure in your agenda. And also leprologists, I want to thank you for your commitment. I want to thank AIIMS agencies. Thank you for their partnership and presence in this conference. The TLNTI, we thank you for your papers, your participation, your teams that came from Lepra, from GLRA. We had participants from GLRA, and other AIIMS agencies were represented, and I believe that is again one more area that IAL would like to work closely with, and I'm so happy that it was well represented. I want to thank the local organizing team. Thank you, Dr. Abhishek, and for your leadership and all that you have done to make this a successful conference, along with Dr. Vikas as the organizing secretary. Thank you, Dr. Vikas, also for all that you did. And of course, we had the dynamic scientific team. Thank you for the work that you did, and also with Sri Parna. Thank you for all that you did to coordinate the scientific events. So on behalf of IL, we want to thank all of you as a team. Yeah, and I hope you'll give us another 5 minutes sometime during this program. We want to say a few more words to you as organizing team. Thank you one and all for being present at this closing valedictory of this conference, Lepcon 2026. Thank you.
Now we move to the most awaited session, that is the prize distribution for award paper. I would like to request Dr. P.N. Rao sir, Dr. Sujay Sunitha sir to kindly join us to felicitate the awardees. The third prize, award paper. The third prize goes to Dr. Pooja Shah from MMC Ahmedabad, and also Dr. Rishabh Sanghai from AIIMS Patna. Please join us on the stage. Dr. Pooja Shah and Dr. Rishabh. Award paper.
वो तो है ये
उसको ये दिलवा देती ना उसको
सुनो
एक मिनट कहाँ है दूसरा बस
सर कब के लिए बुक है सर सबके लिए बुक है सर, सबके लिए ठीक है।
For the second prize in award paper, I would like to call upon Manjot Kaur, PhD scholar from PGI Chandigarh.
पीजी का नहीं, मेरा पीजी का भी मोमेंट बोल दिया,
दो प्राइस
ट्राई कर दिया।
इसका
डाले ना
second prize, Manjot Kaur from PGI Chandigarh, PhD scholar. And for the first prize in award paper category, we have Himanshi Khera from PGI Chandigarh, again PhD scholar. I would request all the winners to collect their award paper and poster certificates from the registration counter. Moving to the poster category, the third prize is awarded to Dr. Soumya Sulgan Mahapatra from AIIMS Patna. The third prize has been shared with Dr. Sangeeta Singh of AIIMS Patna. So we have two third prize in the poster section. Dr. Sangeeta Singh from AIIMS Patna. For the second prize, again we have a tie of Dr. Soumya Raj and Dr. Anisha Biswal. In poster, we have two second prize, Dr. Soumya Raj and Dr. Anisha Biswal. I think we don't have him. Moving to the first prize in poster category goes to Dr. Harshita, PG resident from SIMS Bilaspur. First prize. In the poster category for Dr. Soumya Raj, Dr. Professor H. Karsar will receive the memento. I would request Dr. Professor H. Karsar to kindly collect the memento. Moving on to the next category, we have quiz. For quiz, the third prize goes to MGM Indore, Dr. Akash Jaiswal and Dr. Garima Khandelwal. MGM Indore. Congratulations. In quiz, the second prize winner is AIIMS Jodhpur, Dr. Ayushi Bhargava and Dr. Tushar Pawar. Please give a big round of applause for them. I would request Dr. Anupam Das sir to kindly join us on the dais. The quiz master for Lepcon. Dr. Gaurav Das sir, you also please join. Jodhpur sir. मेरे एक्सटर्नल थे ना मेरे एक्सटर्नल थे second prize. And for the first prize, we have AIIMS Nagpur, Dr. Chetan CM and Dr. Abhijit Birzawasi. Please applaud the winners of the quiz competition. Behind every successful conference stands a team dedicated to the work. It's our privilege now to felicitate a few of those distinguished individuals who have worked behind the scenes. For this, I would call upon Dr. Vartika, Senior Resident, AIIMS Patna, Dr. Shubhashri, Senior Resident, AIIMS Patna, they have worked behind the scenes tirelessly to make this conference a success. Dr. Niharika, Senior Resident, AIIMS Patna, and Dr. Shivani Kumari. The postgraduates of AIIMS Patna have also worked tirelessly to help us plan the journey. So would like to felicitate them. Dr. Zoya, Dr. Rishabh, Dr. Lavanya, and Dr. Mishkat. Also Dr. Soumya Mahapatra.
Now after this, I request Sujay sir and Rajlakshmi ma'am Santosa to kindly felicitate Dr. Sriparna Dev, Scientific Secretary.
Good afternoon, everyone. For next, I would like to invite Dr. Aditi Snehal. Next, I would like to thank the snappers, the event management, who are working with us for last 12 years now. I would like to invite Mr. Adhikari. Mr. Farooq, who has been our support behind the scene, and Mr. Mudassir.
Would like to request Dr. P.N. Rao sir and Sujay Sunita sir to kindly felicitate Dr. Gaurav Das sir for his contribution in Lepcon.
और कौन है? तब तक दूसरे को बुला लेते हैं. And especially I would like to thank the company Dharma Joint for being our prime sponsor. When we were lacking funds, they came up and they really supported us. So I would like to call Mr. Sumit on behalf of Dharma Joint.
So, we would like to, on behalf of IL, also felicitate the organizing team of Lepcon 2026. So I would request our President, Dr. Sujay sir, Dr. Rao sir, and Dr. Rajlakshmi ma'am to felicitate organizing chairperson, Dr. Abhishek Kumarja. So please have a big round of applause for Dr. Abhishek Kumarja. Yes. Next, we would like to felicitate the organizing secretary for the conference, Dr. Vikas Shankar. He has been a great friend. And
I mean, there are no words to tell actually. The way people have done it. Thank you.
Santosh, you can come here.
Santosh, come. Aja, aja, aja. Aja, aja. You come this way.
yeah, thank you. And all the hard work Dr. Svetalina Pradhan, scientific chairperson, she has put in for the program. We would like to felicitate her.
would like to request Dr. Rakhi Gupta ma'am to kindly join us on the dais for her
And
excellent
one
contribution.
more we have for Dr. Punkesh Kumar, who is the treasurer. He's not here? Okay, fine.
मैम का नाम अनाउंस कर
Good evening, good afternoon, everyone. As organizing chairperson, I would like to thank you all for coming. We tried our best for the scientific and everything, hospitality, everything we tried our best. But I know there might have been faults, so I apologize for that. If there has been, next time we will try to do better. I request the delegates to speak and give feedback to us about this conference. Mishra sir.
Mike.
I congratulate the organizing team, Lepcon 2026, for organizing such a nice conference. It was a very good conference, and all the delegates from India participated in it, and we all enjoyed. The scientific session was very nice, and all the catering facility was also good. I hope this will continue, and all the team members, Dr. Abhishek, Dr. Vikas, Dr. Svetlina, and our national president, all participated in such a way that it was a nice occasion, and we all enjoyed. Thank you very much.
Thank you. On behalf of the delegates and the faculty, I can say this is a wonderful scientific feast, well conducted. Within a short period of time, I would like to thank Dr. Abhishek Jha, the organizing chairperson, Dr. Vikas Shankar, the organizing secretary, and particularly Dr. Svetlina, the scientific chairperson. She wonderfully organized all these things in a scientific way, both a lot of delegates. We never expect so much postgraduate students attended this Lepcon in such a high number. And this indicates the young generation dermatologists and other scientists, they're coming forward to continue to work in leprosy. That's a very good sign, probably. That indicates that still people are working and more number in the leprosy field. Till let them continue to work in leprosy field till we achieve zero leprosy. Thank you so much. Thank you so much.
Hello. I really congratulate the team Bihar, Patna for really very well organized conference. And as you said, there might be some lacunae and all. I don't think there was any lacunae left. Everything was perfectly fine. Thank you very much.
I would like to mention on this thing one more thing. Dr. Sujay Sunita sir and Dr. Santosh. We might be the organizers, but I have organized many conferences. This was the first one when they both were so much engaged in this conference. We discussed everything. They knew and I knew, we knew, our team knew everything. So it was wonderful team. And like in last 3-4 months, I have talked to Dr. Santosh more than my wife. So I will miss him from tomorrow. So I request all of you to give standing ovation for Dr. Santosh, Dr. Sujay sir. Wonderful team. I really liked, well, I felt very good working with them. And Dr. Raj Lakshmi also. She was in the scientific. Thank you, everyone.
I would also now request Dr. P.N. Rao sir and Dr. Sujay Sunita sir to kindly felicitate Dr. Irene Matthews ma'am for her excellent behind the scene and on screen help and contribution towards Lepcon 2026.
Close and lunch.
Hope to meet you all in Chennai. Allah meet Chennai में ही ना?
Final हुआ? Chengalpattu. Sir बताएंगे.
Thank you so much, sir. I think with this, with great pride, we can formally declare Lepcon 2026 to have. I would request everyone to come to the dais for a group photo.
सर बैठ के करना है उधर करना है नेशनल एंथम है बताने के लिए है ना खुद ही गाना गिरी को बताया ना गिरी है
I would request everyone to join us first for national anthem. Please stand.
गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय जय हे जय हे जय हे जय 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 हे
I would request everyone to join on the stage for a group photo. आ जाएंगे ना सब आ जाएंगे